Dr. Asha, I think you have to unmute yourself.
Okay, so the program is live now. Sujeshri, will you please start?
Yes, ma'am. So I invite everyone to today's Searchlight 29. It's on updates on chronic pelvic pain, endometriosis. This is in association with OB-GYN societies of Patiala, Rudrapur, Roorkela, Saharsa, Shillong, Shahjahanpur, Sitamarhi, Shimoga, Siliguri. We cordially invite all the faculty and the delegates who've logged into this program. And firstly, I would like to introduce...
I will introduce you first. Welcome, Sujeshri, my dear convener to this program. Sujeshri Sangeeta is the secretary of Bhimavaram Obstetric Gynec Society. She runs 2 hospitals, Seshadri Hospital in Palakol and Seshadri Hospital in Malikapuram. She is the founder secretary of Bhimavaram Society, has Shan Ratnam Young Gynec Award and the Foxy Dheera Award.
Yeah, ma'am, we'll keep it short. And moving on forward, it gives me great privilege to introduce our program director, Dr. Asha Jain, ma'am. We've done almost 29 programs together, so hopefully we have more innings further. So introducing Madam. Next slide, please. So Madam currently is a director of SMSA Hospital Raipur. She was the medical director of CPRS. She has also been the elected member of CG Medical Council, Zonal Chair, Foxy Food, Drug and Medico-Surgical Equipment Committee, West Zone. She's the chairman of Mission Pink Health, IMA Raipur, executive member, ISCP, Chhattisgarh, ISAR and SFM chapter. Previous posts held by ma'am, she's been the president of Raipur OB-GYN Society, vice president of IMA Chhattisgarh, and president of Rotary Club of Raipur North. And madam has received training in colposcopy. She's also an instructor in the same. So requesting ma'am to please take over and move forward.
I welcome all dignitaries to this 29th episode of Searchlight series of webinars. And I would have to share again, I'm sorry. We would first take the blessings of the divine before we take the program forward. So,
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा.
thank you all dignitaries for joining in this virtual lamp lighting ceremony. Now, I would like to introduce our chief guest for the evening, Dr. Mandakini Meghnam. This is her CV. It is so big that she is currently the National President, Association of Medical Women in India, Central Council. She was the chairperson ICOG Foxy 2020 to 21. She has many books, many awards, and more than all of this, she is our own very dear, very loving Mandakini ma'am. So, ma'am, I invite you for your words of blessings.
So, good evening, everyone. And it's what a pleasant evening I can see. So, thank you. At the outset, I would like to thank you, Asha, and all my, faculties here, Dr. Anuruddha Kulkarni, Dr. Pratibha Singh, guest of honor, and Dr. Ranjana, and all of you, Dr. Meenu, the speaker. I think, Asha, you are touching upon very, very important topics. I really actually recollect my chairperson ICOG days when we all were, hauled in our houses. We were doing courses after courses. This idea of doing a proper certificate course in the endometriosis came from none other than Ramani, who is the authority, I think Pratibha must have joined you, or also must have joined that time, because we had nothing to do but to attend the ICOG lectures. And it has become so popular. And that opened the era, how much endometriosis is causing trouble, chronic pain, and it requires, some kind of remedies, whether it is mild or whether it is a major organs affecting. Also, Asha Rao done a lot of work, and we three of us conducted that course for 3 days. And today also you have given a very different kind of aspects to that, especially the ultrasound. I was talking to Dr. Anuruddh, and he has given me so many ideas. I think our viewers are going to be benefited. That is one thing. And second thing is about the even Dr. Meenu Agrawal and all of you. I think we are going to do justice to the to this. And Asha, I want to really congratulate you. I remember my days of last year, July election. I can't forget that. And that time, actually, my Gyan Ganga series was a very hit. And it spread. Even now also, we are having this Gyan Ganga. And this is going on. Knowledge never stops, whether you are contesting or not. So I want to really congratulate Asha for this wonderful webinar. This is 29th webinar of the Searchlight. And you have touched upon each and every person. And you brought all our friends whom we have not met since many months, I can say. Pratibha, we were in Jaipur, we were, all of you, we have been physically at your place, and it was wonderful opportunity. So Asha, all the best for your initiative. I am there. मैं हमेशा बोलती हूँ कि जब मैं इंदौर में थी, born and brought up in Indore Medical College was my college. That time Raipur was a part of it. हम लोग जब बच्चे होते थे, हम लोग नकाशा बनाते थे, तो छत्तीसगढ़ तो पीछे आता था, और जब उसको कट कर दिया ऐसे डरी तुमने तो हमारी लेग ही कट कर दी, सो व्हेन द छत्तीसगढ़ वाज, सो मेरा बहुत फेवरेट था एमपी का नक्शा निकालना, एंड छत्तीसगढ़ वाज मिलिंग. So I think, Asha, all the best. We are all with you. You are such a sincere and dedicated person and doing a great work. And I think you will get through this wonderful post also, and we are there. So with all this, thank you once again for inviting me. And remember me whenever I'm, you can, I will be there for you. Thank you. Bye.
Thank you so much, ma'am. Thank you for being there. My first program also, I had you in my program. And now this is 29 and you are here.
Yeah.
And now I would like to introduce our guest of honor, Dr. Pratibha Singh, ma'am. She's an MBBS, MD, FICOG, SIM. She is a consultant laparoscopic gynecologist and IVF person, director of Healing Touch Hospital. Very nice name. She is also the chairperson of International Academic Exchange Committee, FOXY, currently up to the year 25. She is a chairperson, Fertility and Aging Committee of IMS, President, Bhagalpur Menopause Society, VP. Again, a lot of things, but ma'am she writes, she arranges a lot of programs, makes beautiful collages. So welcome, ma'am. We are really honored to have you here.
Thank you. Thank you, Asha ji. You don't need to call me madam. We all are colleagues. And first of all, a very good evening to all of you. And I'm really very happy today to be the part of this today's program, and I'm really very amazed to see that this is the 29th series they are having. And first of all, my regards to our chief guest, Dr. Mandakini Megh ma'am, and whom what can I say? She is everything for me. She is such a loving person. Whenever I need her, she is there for me. And she has helped me a lot everywhere whenever I wanted her. So it's really very nice to see you today. After a long time, we are meeting each other on virtually. So thank you, madam, for everything. And today I'm really very happy to be with you and sharing this dais with you. It's really a great privilege and honor for me. And Dr. Asha Jain, what can I say about her? She is really doing wonderful work. And today again, she has arranged this very good program on endometriosis, which is such a crippling disease. And our speakers, which she has chosen, it's mainly going to talk on ultrasound and the laparoscopy, which are the very important modalities, diagnostic as well as therapeutic modalities for managing endometriosis. So we have very good personality, Dr. Anirudh Kulkarni and Dr. Meenu Agarwal, who will be talking on this. So I don't want to waste time in talking by me and telling what is endometriosis, because they are the best persons and they are the experts going to tell about that. And along with this, we have another panel discussion on induction of labor. So we are.
Sorry, ma'am. The panel is also on endometriosis. That is a
Okay.
typing error.
Okay. So that is what I was thinking, why it is on induction of labor. Yeah. Okay. So again, all about endometriosis we are going to listen today. So very good program, Dr. Asha Jain ji, and thank you for including me in this program. And I also want to congratulate you for doing such wonderful work and such spreading knowledge to everyone, to us, to our colleagues, to our juniors, to delegates. Everybody should watch such programs, because this will help us to improve our skills as well as to improve our day-to-day private practice. If we are in private practice, then it is really required that we should be updating ourselves again and again. So with these words, I just want to congratulate Dr. Asha Jain for such wonderful program. And I also want to wish her all the best for her future elections. And with this, thank you so much for including me in this program. Thank you, Dr. Asha.
Thank you so much, Pratibha ma'am. Thank you for being here with us this evening and sparing your precious.
I'll be there. I'll be listening. I want to really listen Dr. Anirudh talking on ultrasound. Yeah. So thank you so much.
So with that, Dr. Subhash Malya has not been able to join us so far, so we will take his words when he joins. Meanwhile, I request Sujeshri, would you please introduce our chairpersons?
Yeah, sure, ma'am. So moving on to the first session, we have Dr. Anupama Ravi Futela with us. She's a graduate of KGMC from Lucknow. She's done her master's from MAMC New Delhi in 1996. She's received her fellowship in reproductive medicine from NUH, Singapore. She is right now the senior consultant at Futela Hospital in Rudrapur. She has gifted the first IVF baby in that region. So she is also the primary member of State Surrogacy Board. So welcome to today's session, ma'am. It's an honor to have you with us. Moving on, we have Dr. Sudharani Pradhan. Madam is the HOD in the OB-GYN department, and she's also the president of her society, and she's the member of IMA. Welcome, ma'am, to today's session.
Hello.
We have Dr. Kalyani Singh with us. Madam is a professor emeritus at Lord Buddha Koshi Medical College and Hospital, Saharsa. She is the founder and chairman of the Lord Buddha Koshi Medical College and Hospital, Saharsa. She's also the professor and head of department there. Welcome, ma'am, to today's session. It's an honor to have you with us here. I request one of the chairpersons to please introduce the speaker for today's session. Ma'am, request one of the chairpersons to please introduce Dr. Anirudh, sir.
Hi,
Yes, please
I'm
go
Dr.
ahead,
Futela.
Anupama.
Yeah, please go ahead, ma'am, please.
Hi, I'm happy to introduce Dr. Anirudh Kulkarni, who's the founder, director, and faculty at Scholar MD, a premium ultrasound training program. And he's also a renowned radiologist at SRIMS Aurangabad. Can you show me the, yeah. And he's basically more interested into ultrasounds of urogenital and neck and pediatric. He's also written 2 chapters for radiology textbooks, and many indexed publications are there on to his credit. And he's an innovative skill developer in ultrasound teaching, also enthusiast for cricket. Congratulations for the World Cup win, Dr. Anirudh. And wow, we'd love to see somebody avid backpack traveler. Uttarakhand is waiting for you. I'm from Uttarakhand. So welcome, Dr. Anirudh. We want to listen to what new things you have to tell us about endometriosis, the enigmatic disease, and the ultrasonography along with it. Thank you.
Thank you very much for this wonderful introduction. Can I share my screen, please?
Yes, sir, please go ahead. Yes.
So in next, everything is visualized well. I mean, no issues. Okay. So
Yeah.
in next 25 minutes, probably I will be talking about endometriosis spectrum and the IDEA protocol-based transvaginal ultrasounds, which can be really helpful in coming to a conclusive evidence of endometriosis. That's very important. No disclosures. E-medicine serial loop belongs to my center. Articles have been duly acknowledged and taken from the literature. Reference has been duly acknowledged for that. The systematic approach to sonographic evaluation of pelvis, the first study which was dedicated for a classical approach of protocol-based wage was done by Dr. Kondus and Dr. Vande Bosch. And the kind of approach they have brought in, it has been so simplified that we can come to a conclusive evidence of stating that it's nothing but endometriosis. Now, most important is that we take transvaginal ultrasound, particularly gynecological pelvis, as a very easy one. We don't spend more than 3 to 5 minutes for assessing the same. There was one study which was done by how long does a transvaginal ultrasound examination takes for endometriosis. And everybody has failed for that in 2021. And ideal time for evaluate transvaginal dedicated ultrasound study has to be more than 20 minutes for that matter. The delay in diagnosis of endometriosis is because of overlapping symptomatology, lack of efforts which are proactive in good ultrasound imaging. Almost it takes around 8 to 9 years to diagnose pelvic endometriosis. Now, the typically ultrasound, which is followed by MRI, which is followed by the laparoscopy, is the course. Most of the times, the approach has to be a detective-like approach because the reports everything is normal, no abnormality detected, tenderness is seen, and you have to correlate clinically, but no conclusive statement as far as reporting is done. So reports, what does they say? Bulky uterus, what is the cause? Enlarged uterus, tenderness noted, diffuse heterogeneous thickening of the wall of the uterus with altered motor ecotexture, tiny cystic spaces, mixed coarse ecotexture, hypoechoic infiltrates, and the answer by more or less most of the radiologist is inadequate. So the gynecologist, they say, "Bhai, what is your opinion? Kahna kya chahte ho?" And that is the why dedicated approach needs to be there. So how do we learn early detection of endometriosis? Look for anterior and posterior fornices position as far as the transducer is concerned. Demonstrate the sliding sign of the cervix over the POD. Mobility of all the structure, including the ovaries and adjoining area in case of non-symptomatic cases. And practice in case of advanced cases where demonstration of a torus or tracing of uterosacral ligament in sagittal and transverse plane is possible on routine examination. Not only that, whenever you are looking through posterior fornices position of the transducer, you need to evaluate the deep infiltrating endometriosis nodule. So what is more important is that you need to dedicate more time. You need to learn the advanced techniques to demonstrate the POD, sliding sign, torus and uterosacral ligament, and you need to upgrade your system for that matter so that you have a high frequency transvaginal transducer which can depict the bowel nodules very easily. So location of
Can you elaborate what is torus, Dr. Anirudh?
in due course of time, probably I will show some of the slides as well as I will demonstrate one torus very nicely. If at all you are not convinced, probably, then I will once again come back to torus once again. So location of endometriosis is superficial and deep one. So superficial, ovarian and deep one. Superficial means less than 5 millimeter as far as the depth is concerned. Ovarian means ovarian classical endometriomas, and deep means anterior and posterior compartment demonstrating classical deep inflating endometriosis. And this is what is IDEA protocol. So IDEA protocol is consisting of 4 steps of evaluation. The first step is routine evaluation of uterus and adnexa for demonstrating specific signs of adenomyosis and endometrioma, which we are all trained for doing the same. The second step, for that matter, which usually I do it last, is evaluation of transvaginal sonographic soft markers, site-specific tenderness, and ovarian mobility. Because if you try to do it at level 2, the remaining portion of examination the patient may not allow because of site-specific tenderness. The third one is assessment of status of POD using real-time ultrasound-based sliding signs. Let us see how does the sliding sign is related. The assessment of deep infiltrating endometriosis nodules involving anterior and posterior segment, that's the fourth step. But traditionally, I do the second step as a last step. The standard examination for years together has been uterus and cervix, endomyometrial junction, ovaries and adnexa, and POD. But we need to examine all symptomatic patients and extend our examination for evaluation of introitus, urethra, bladder wall and bladder base, ureters, which are significantly seen in most of the patients, sliding sign of retrocervical region as well as POD, and quick survey of kidneys and retroperitoneum and rest of abdomen is mandatory in each and every patient of pelvic ultrasound, because there are so many signs which are hidden in the abdominal cavity, probably will overlook the same. So advanced transvaginal ultrasound is consisting of torus, uterosacral ligaments, demonstration of ovarian ligaments, broad ligament survey, demonstrating the lower 1/3 portion of the bowel, mobility and site-specific tenderness in case of indicated patients. So the normal scan traditionally depends upon age of the patient, position of the uterus being anteverted, retroverted, or mid position. At the same time, evaluation of urethra, bladder, uterus and cervix along the long axis, uterus and cervix along the transverse axis, ovaries along the long and the transverse axis, at the same time taking all the measurements in long and transverse axis. And the POD is traditionally evaluated in the long axis for that matter. So let us see what we can do. So always start examination with evaluation of urethra. Slowly introduce your transducer into the segment so that you can evaluate the lower 1/3 of ureters very, very easily. And how we can do, we'll see in next few slides. So here you can see very easily, this is the anterior lip of cervix, this is posterior lip, and slowly I'm advancing the transducer so that I can see the position being in the anterior fornix. So this is urethra, this is vagina, and behind the vagina is the lower part of the anal canal. So this is the examination at the level of introitus in a long fashion. So at the same time, you can evaluate the bladder base over there, and nextly you can evaluate the lower 1/3 of ureter, and you can evaluate it by dynamic examination, and you can put a color Doppler to demonstrate the ureteric jets, which can be seen very, very easily. So whenever the endometriosis is involving lower 1/3 of ureter, that can be very well depicted on transvaginal examination, and you can search them and dogmatically report the same. So the step 1 is a routine assessment, looking for adenomyosis, looking for ovarian endometrioma, looking for adhesions. So the position of the uterus can be anteverted or a retroverted or a retroverted and retroflexed. So whenever it's a retroverted and retroflexed, we should have a high degree of suspicion that the patient is having adenomyosis, number 1, or that could be a retrocervical fixity because of which the fundus is dipping posteriorly. The most important maneuver for that matter is shift of transducer from anterior fornix to posterior fornix. This serial loop I have taken from website. The important features of adenomyosis recognition is what is called the pattern recognition. Now here you can see it's a bulky uterus, and this is the cut section which demonstrate extensive features of adenomyosis which can be easily correlated on transabdominal scan as well as transvaginal scan. Here the cervix, which is very short one, can be appreciated on transabdominal scan, and the multiple areas of adenomyosis can be identified. So what are the classical features of adenomyosis? Disruption of endomyometrial junctions, a presence of a endometrial echogenic striations which are extending from endometrium into endomyometrial junctions, multiple speculations which are arising from the endometrium into the endomyometrial junctions, and inhomogeneous areas, asymmetrical thickening of the wall of the anterior and posterior wall of uterus could be one of the features. So endomyometrial junction has gained a lot of importance in last 1 decade. We must measure the same, and this can be easily correlated on MRI very well. So at the same time, we must understand that presence of islands or speculations or striations from the endometrium, which is disrupting the endomyometrial junction, extending into the myometrial component, could be one of the features of adenomyosis. Now here you can appreciate the same, and which can be depicted very nicely. So endometrium and the small nodules or islands adjoining to the endomyometrial junctions and small tiny cystic spaces also can be visualized very well. So the spectrum of adenomyosis which extend from asymmetrical thickening of the one or the other wall to extensive adenomyotic islands and cystic spaces adjoining endomyometrial junction. So whenever I want to report adenomyosis, there is 7-point protocol which says presence or absence of adenomyosis, location of adenomyosis in terms of wall, the type of adenomyosis as a focal or a diffuse one, the variant of adenomyosis as a cystic or non-cystic, and the layer of involvement, that is layer 1, layer 2, layer 3, or combination of that, that is layer 1 and 2, layer 1 and 3, or extensive one extending beyond the uterus into the endometrium, into the POD, and forming deep infiltrating endometriosis. You can comment the extent of the disease as a mild, moderate, and severe. And if there is a focal adenoma, as nicely seen in endometrial here over here, the size of the lesion also can be mentioned. Apart from adenomyosis, the next one to look for is ovarian endometrioma. So this is classical ground glass appearance, which is seen in case of ovarian endometrioma. Here you can see that the both ovaries are in the POD. At the same time, they are stuck to each other as well as posterior surface of the uterus. So it is our duty to demonstrate the ovarian mobility and ovarian adhesions. So normally ovaries, they are freely movable along its own axis in respective foci, as well as its relation to the posterior surface of the uterus or the ovarian fossa and interiliac vessels in that segment. So whenever there is a restricted mobility or there is a fixity as it is seen in this patient, both ovaries are stuck to each other and classical ovarian endometrioma is seen. So demonstration of ovarian mobility and adhesions is the next thing. On many instances, you will find that there is a hematosalping, which is characterized by a partial septi, which are arising from one wall not reaching to the opposite. There is a coarse debris echo involving the tubular or retort-shaped structure in the adnexa, classically described as a hydrosalping or a hematosalping. The next step is what is a POD status or a sliding sign. So your transducer is in the anterior fornix. At the same time, you can see the cervical canal very well, and you need to see the cervical sliding over the bowel. When your transducer is in the posterior fornix, you cannot see the cervix at that period of time, but you are able to look at the bowel adhesions as well as the bowel nodules. So position of the transducer in the anterior fornix and position in the posterior fornix in anteverted and retroverted position. Let us see how it looks. Now here, my position of the transducer is in the anterior fornix. I can see the cervix very well. I can see that the mobility of the cervix over the remaining portion of the POD very, very easily. That means my sliding sign is absent and sliding is very well seen. Now, I need to shift the transducer from the anterior fornix to the posterior fornix. Now, this maneuver helps me to allow to look for any nodules which are occupying in the posterior vaginal wall, which is mending over the transducer. At the same time, and I am able to see the POD as well as the bowel over there. So the posterior fornix examination is very, very important, and these two maneuvers are important when the position of the uterus is in anteverted. So when it's a retroverted uterus, minimal amount of fluid will allow you to demonstrate the retroverted position very well. My transducer is bending over the posterior vaginal wall, and I'm going to see how does the posterior uterine wall and the fundus has a mobility over the structures behind, the same over the vaginal wall and the POD. So position of the transducer and position of the uterus both are equally important in demonstrating the sliding sign in those individuals. Now here you can appreciate. Now here in the first cine loop, you can appreciate that both the movement of the retrocervical region is independent of structures behind the same. Whereas in this cine loop, you can see that both of them, they are moving in conjunction with each other, which means that there is a fixity of structures of retrocervical region with the area behind the cervix over there. So sliding sign is absent here when the uterus is anteverted. Now, in case of a retroverted uterus, now in this cine loop, sorry. So in this cine loop, you can appreciate that there is a minimal fluid, but the fundus and the posterior wall of uterus is easily mobile over here. But here, there is a fixity of structure of adjoining nature involving the fundus. At the same time, you can appreciate that there is a small hypoechoic area, which is in the subcervical nature, which is nothing but a superficial variant of endometriosis over there. So there is a retroverted uterus with sliding sign being absent. The third step is to demonstrate the nodules of deep infiltrating endometriosis. Deep infiltrating endometriosis means involvement more than 5 millimeter, usually associated with cyclical bleeding, inflammation, and fibrosis. So traditionally, you will have a hypoechoic area, which is speculated one, which is surrounded by the fibrous area, which is a hyperechoic one. So this is black in color and this is white in color. So whenever we are suspecting deep infiltrating endometriosis nodules, it has to be in the anterior compartment. So we need to look for bladder and ureters. If it is in the posterior segment, then posterior compartment, then we have to see posterior vaginal wall, ligaments, that is torus and uterosacral ligaments, and the bowel. So the posterior to vaginal fornix is this area. You have a rectovaginal septum over there. Then behind the cervix area, this behind the retrocervical area is the area of torus and uterosacral ligament. The same area is also we need to look for lower part of the rectum. On many instances, if there are multiple focal areas of endometriosis involving anterior compartment, posterior compartment, and the rectum and the bowel, it is called as the multifocal, or what we call as the frozen pelvis. So this is an image given by Dr. Vikram Lokhande, and here you can see classical deep infiltrating endometriosis of multifocal in nature. Now, whenever you look at the posterior vaginal wall, we need to see that the small amount of fluid adjoining that can be a normal. We need to look for free mobility of the cervical portion over the posterior vaginal wall. Not only that, as my transducer is sliding over the remaining portion of the bowel, I need to look for any kind of nodules involving the posterior vaginal wall or any kind of nodules which are involving the bowel loops over there. So this is what the torus, as she was asking. So this is a small area of bump which is seen behind the retrocervical compartment. I think you are far more expert than me to label the same. And on the either side, we have a uterocervical ligaments for the same. So how do you demonstrate the same? So you first take a long view of uterus, identify the area behind the retrocervical portion, pass a line from the bladder attachment in the lower part of the anterior lower segment, look at the internal os. The posterior to internal os is the posterior aspect of the cervical body, and the rotate the transducers transversely. So that's the area where you will find a hyperechoic nodule, which corresponds to this area. And then you follow the torus on either side, that is on the right side and the left side, where it's a bright white hyperechoic line, which can be seen very nicely. So whenever you find out a small hyperechoic nodule involving the uterosacral ligament or the torus, you can define them very well. So let us see how you can see. So this is the anterior lower segment. This is a bladder reflection over there. So this is the internal os. This is the area behind the internal os. And what I am doing is I am moving. So this area, this hyperechoic bump along the posterior aspect of retrocervical region is a torus. Now this white hyperechoic line, which is extending on the left side, is a uterosacral ligament over there. And the same time, later on, you can visualize the ovary over there. And on the right side, you can extend that examination as a bright white hyperechoic line, which goes onto the right side as a right uterosacral ligament. So it's very, very easy to demonstrate and very, very easy to understand. And whenever the abnormality, so unless until we start identifying this hyperechoic torus area, which is nodule behind the retrocervical portion, it's very, very difficult to identify the deep infiltrating endometriosis. These are the two small senior loops. I bought it from Dr. Vikrant Lokhande. And here you can, this is a normal torus and uterosacral ligament on both sides, and these are the abnormal with along with a small amount of fluid collection over there. So my duty is to look for some degree of thickening of this torus area. This is hyperechoic along with a small hypoechoic rim adjoined to that. There is a fixity of structure of the uterosacral ligament on this side. You can see little bit of speculations which are noted on this side. So after demonstrating normal or abnormal torus and uterosacral ligament, the next thing that we look for is bowel nodules. So in case of bowel nodules, it is duty to demonstrate the muscularis mucosa. This is classical muscularis mucosa. And whenever there is a presence of a hypoechoic nodule involving the muscularis mucosa, that means it's a deep infiltrating endometriosis. And it can be a multifocal one. So whenever it is bowel nodules which are able to define, then we need to calculate the distance from the anal verge and the distance from the torus as well. And we need to define whether it's a stenosing one or a not stenosing one. So how do you look for the same? Now, can you see this bowel loop very nicely here? Now, as I need to trace it from the anal canal and try to trace it as distantly as possible and see whether it is completely normal. Now, here I can see that this hypoechoic muscularis mucosa is well preserved. Now, in contrast to that, now my transducer is in the posterior fornix. I cannot see the cervical canal over there. But here you can make out that is a saucer-shaped lesion, which is hypoechoic one, which is causing indentation over the bowel lumen as well as the narrowing of the bowel in that place. So you cannot see the cervix. So you are evaluating the posterior vaginal wall and the POD. You are evaluating the nodules involving the posterior vaginal wall as well as in the bowel. Now, how does the bowel looks like? Now, this is a classical, what is called as the signature of the bowel. It has got a central lumen. There is a mucosa and submucosa over there. And this is muscularis mucosa and this is the serosa. So it is my duty to see whether I am dealing with some kind of a hypoechoic lesion which is involving the serosa and the muscularis mucosa at the same time is extending into the submucosal component, and many instances it can be obliterating the lumen of the bowel which is seen in the POD. Let us take one example. Now here you can appreciate I am tracing the bowel here, I am tracing the bowel here, I am tracing the bowel here, and now you can make out that there is a saucer-shaped lesion over there which is causing some amount of luminal narrowing, and it is involving the serosa and the muscularis mucosa on that. So this is a classical bowel nodule which is seen over there. It's very classical nodule which is seen nicely over there. So whenever you find out that there is a nodule, you have to take measurements of length, depth, and the width. And then on many instances, distantly separate surrogated markers of stenosis also can be evaluated, which can be done by calculating depth of the nodule if it is more than 10 millimeter, width of the nodule which is obliterating 50% of the bowel, and angle of the nodule also can be calculated as relation to the muscularis mucosa, which is normal. So measuring the nodule and calculating the percentage of stenosis and depth is easily possible. Now coming to anterior compartment, where my duty is to demonstrate trigone, base of the bladder, which is adjacent area to cervix and vagina, and intra-abdominal dome of the bladder. We need to understand that lower 1/3 of ureters can be very nicely and easily seen, and so is the bladder dome and the bladder base. So whenever you want to demonstrate the ureters, first go to the internal iliac vessel and try to demonstrate the ovarian fossa, then come down to closer to the cervix, demonstrate the bladder base at the trigonal area, and usually the tubular structure which is seen closer to the bladder base is nothing but the lower 1/3 of ureter. So let us see how you can see. Now here, can you appreciate the lower 1/3 of ureter very easily? And you put a color Doppler jet, then you can see both the lower ureter is throwing good color jets onto that area. So my duty in stating that there is no stenosis involving the vasoaquatic junction on both the side, the lower 1/3 ureter course is absolutely normal. So tracing becomes more and more easy. So this has to be my first step in demonstrating the introitus and lower 1/3 of ureters as well as the bladder base, which is nicely seen whenever I am introducing the transducer from the vaginal introitus adjoining to into the internal os area over there. So whenever you find that there is a hydroureter nephrosis on that side, you try and demonstrate the entire length of ureter in the upper part. As it crosses the internal iliac vessel, it dips down into the pelvic brim and goes towards sciatic notch and goes medially. But at the same time, it can be very nicely seen whenever there is an extensive bladder endometriosis. Now here you can appreciate that there is a bladder endometriosis over there. An extensive area of adenomyosis also is noted in these patients. So hydroureter nephrosis you can appreciate on this side. At the same time, you can appreciate that there is a remarkable hypoechogenicity involving lower one-third of ureter, which is surrounded by hyperechogenicity. So this is classical involvement of lower one-third order of ureter because of endometriosis. So in such patients, if you want to dogmatically present, then you can do CT, but better than that would be MR in those individuals. The last step to demonstrate the same is what is called as a site-specific tenderness or mobility. In fact, IDEA group has defined it as a step 2, but I usually prefer to do it at the last because your entire examination is very gentle while talking to the patient. Your left hand can be on the suprapubic region giving bimanual sustained pressure. As soon as your entire examination is complete, you can catch hold of specific area of tenderness between your suprapubic pressure areas as well as your transversal pressure areas through your transvaginal fornicis evaluation. So judge the mobility and try to find out the tenderness point. And if it is associated with an hypoechoic area, which is spiculated one, adjoining with hyperechoic area, which is lobular one, then probably you are dealing with some degree of specific site of tenderness and mobility associated with deep infiltrating endometriosis. Now, how do we can learn early detection of endometriosis and improve our techniques? Always and always look for anterior and posterior fornix position during your routine examination when the patient is symptomatic. Demonstrating in sliding sign and mobility in all normal individuals so that you can identify them in case of symptomatic individuals. Practice demonstration of a torus. It's not difficult at all. Just to retaliate it once again, long axis of the uterus, identify the lower segment, identify reflection of the bladder closer to internal os. The area behind the internal os is the retrocervical portion. Rotate your transducers transversely. Rotate your transducer transversely, and then you try to demonstrate that hyperechoic nodule behind the cervix and demonstrate the uterosacral ligaments on either side, which is nothing but a hyperechoic reflection for the same. So reporting expectations by the laparoscopic surgeon is that you should mention the uterus, position of the uterus and detailed analysis, ovaries, position of in presence or absence of endometrioma, fixity and tenderness, retrocervical area of deep infiltrating endometriosis, demonstrate torus and uterosacral ligament for presence of absence of a hypoechoic nodularity surrounded by hyperechogenicity, fixity of the structures of posterior vaginal wall areas, bowel areas for DIE, presence or absence of a bowel nodules and assessment for its stenosis. If multiple areas of deep infiltrating endometriosis involving anterior and posterior segments are seen, they need to be commented. And as I stated, no examination is complete unless and until you demonstrate ureters and kidneys and bladder for that matter. At the same time, you need to say that the retroperitoneal compartment is free of any lymph nodes for that matter. So role of MRI, more or less, is a problem-solving tool. And more or less, it has to be on 3 Tesla because you can identify the disease extension very, very easily. The surgical intervention, whenever it is indicated, can be commented to a great extent as far as surgical planes are concerned on MRI. So this is a classical bilateral ovarian endometrioma as well as deep infiltrating endometriosis, where fluid-filled blood levels can be seen in case of both the ovaries. Now, I am demonstrating 2 cases, very classical cases, bilateral ovarian endometrioma and a classical large area involving the bowel loop over there. And you can see that the muscularis mucosa is involved over there. Again, ovarian endometrioma over here. I am demonstrating the bowel loop. Here, the muscularis mucosa is seen very nicely. As I am going more towards the retrocervical region, I can demonstrate that there is a large area of a bowel endometriosis, which is nicely seen. Now, here you can appreciate bilateral ovarian endometrias as well as the bowel changes behind the retrocervical portion. Both the ovaries, they are stuck to the posterior surface of the uterus, as well as there is a fixity of the ovaries in the POD region over there. One thing we should always remember that wherever we are demonstrating the ovarian endometriomas, we should always comment for presence or absence of a solid areas within pre-existing endometrioma, because pre-existing endometrioma subsequently on rare occasions can get converted into endometrial carcinomas. So the crux is that never accept any report which state that adenomyosis cannot be commented or deep infiltrating endometriosis cannot be seen on transvaginal ultrasound. Always and always ask for specific questions. What I personally believe is that the quality of imaging report is entirely dependent on question posed by the clinicians. If you ask more questions to your radiologist, he or she will improve in due course of time. And one maneuver, if I want to comment that one every should try and follow, is shift of transducer in case of anteverted uterus from anterior fornix to posterior fornix to evaluate the retrocervical areas, the PODs, the fixity, and the torus and the uterosacral ligaments. So thank you very much for your patient listening. I think I have not taken much time. Still, it is 30 minutes for more or less. So protocol-based ultrasound, systemic ultrasound, and reporting in each and every cases is very important, because across all professions, consistency is the direct product of work ethics. Thank you very much for your patient listening.
Thank you so much,
Thank
sir.
you so much.
Over to you, chairpersons. Dr. Anupama.
Yeah. She would have any concluding remarks, you can please.
Thank you, Dr. Anirudh. I wanted to add one more thing that usually it is. Recently, I bought a ultrasound machine. I usually have the older machine was the E6 machine, and I had to buy another one. And I saw that that cheaper machine, which was around 10, 11 lakhs, the same patient in which I was looking at an endometrioma on my bigger machine, I could not get a very good image quality. So it is actually like you said that in MRI, at least 3 Tesla is required. Similarly, the ultrasound machine, all of us gynecologists should understand that it is also the quality of the machine which matters. And we tend to miss, most of us who are doing ultrasounds, if we have a better machine, it is very, very easy to diagnose endometriomas. That typical ground glass appearance is so easy. What Dr. Anirudh has told in detail is the steps which we need to practice more and more now, that we are usually just looking at the uterus and the ovaries, and we are not actually putting up time at torus and the uterosacrals and following the bowels. So that has been very nicely, elaborately shown in that video. And we need more and more repetitions of such videos to learn better. Thank you so much, Dr.
I think we should. I think gynecological ultrasound should not be a 2 minutes job in stating that the uterus is normal,
Yes.
ovaries is normal, there is a minimal fluid in POD. There is so much of information which is hidden in the pelvis, which is very, very important. I think, and it has got a very, what you can say, very easy learning curve. It's not that difficult to understand and learn. And you all are doing laparoscopic surgeries to such a great academic excellence. I think you can correlate these two findings very, very easily, and
Much better.
can reach to a much better highs as far as the
I
academic.
personally feel that gynecologists, if they are doing the ultrasounds, they can correlate so much better because you are actually doing the scans as well as the laparoscopy. Whereas radiologists have to, follow it
Yes,
with
yes.
a surgeon.
That
So
is
our learning curves can be better if we go on doing for that. Although, you know what, Anirudh, I feel that gynecologists are mostly so busy with ops practice people that they really do not invest that much of time. That is the reason why we do not invest too much of time doing the ultrasounds. But that is what is required for endometriosis patients.
very
That
true.
is really required. Okay, thank you.
Thank you.
Thank you so much, sir. Thank you. And Dr. Anupama, you just said that, you want to watch the videos again. So the same link will be available for everyone to watch later, because this is going live on YouTube and you can share it and also watch it at your convenience.
Dr. Anirudh, we just saw one of your slides. It was showing your address, email ID and all. So you are actually
He's in
doing some
Aurangabad.
scholar program also. That is what I learned.
Actually, we have a fetal medicine training program and a gynae training course. Myself, Dr. Ashok Khurana, Dr. TLN Praveen, Dr. Manju Virmani, Dr. Bimal Sahani. We are conducting that course in Mumbai.
You know the bad part about it? It is only for radiologists.
At present, at present,
At present, it's only for radiologists.
at
So
present, that's because see, it's not. See, I personally believe whoever does a good job should be allowed to do. That is what my personal opinion is that. But only thing is that as on date, there is so much of what you can say lack of knowledge and expertise in my own community. So I want to devote more time for my own fraternity for that matter.
No grudges. We want to push our fraternity. So you are absolutely okay with that.
thank you, sir,
Thank you.
for
Thank you very much. Thank you for
sharing your
inviting.
information with our community. And you've done it wonderfully, sir. Thank you
Thank you.
so much.
Thank you. Thank you
And
very much.
now I would like to invite Sujeshri to introduce
ma'am.
our next chairpersons.
Yeah, moving on to the next session. Our chairpersons for today we have Dr. Sarita Agarwal with us. Madam is a consultant gynecologist at Agarwal Maternity Center, Patiala. She's also currently the president of Patiala OB-GYN Society. She has also been the president of Society of Fetal Medicine, Patiala chapter, and her fields of interest are high-risk pregnancy and infertility. Welcome to today's session, ma'am.
Thank you so much. Thank you.
So the next chairperson is Dr. Gyuding Holang. I hope I got your names right, sir, who is the past president of Shillong OB-GYN Society. It's an honor to have you with us today, sir.
Thank you. Thank you.
And we have Dr. Kirti Tandon with us. Madam is the president of Shahjahanpur OB-GYN Society. Welcome, ma'am, to today's society. Today's program, ma'am. And I request one of the chairpersons to please introduce the speaker, Dr. Meenu Agarwal. Would Dr. Gyuding, sir, please with the honor? Yeah. Yeah,
Okay.
please, sir, go ahead. Yes.
It's a privilege to introduce Dr. Meena Agarwal. She's the president of Pune OBG Society 2023-24. She is elected Secretary General of International Society of Gynecological Endoscopy. She was the chairperson of the Imaging Science Committee, FOXI, from 2018 to 2021. She's also a course director of international training courses in UAE and at American University of Sharjah.
That's fine, sir. Dr. Valang,
Yeah.
sir.
Okay. She has so many other publications. She has got so many awards. And we are so happy to have you, ma'am, for this session. And we look forward to having a very enlightening time with you. Okay, I hand over the time to you, ma'am.
Thank you. Thank you, respected chairpersons, and thank you, convener, Dr.
Thank you,
Asha.
Dr. Meenu. I would like to just add that ma'am is going for Vice President Foxy this year. So
yes,
all
thank you.
the best to you, Dr. Meenu.
Thank you so much. So thank you, Dr. Asha Jain, for conducting these courses every week tirelessly and very amazingly with excellent speakers like Dr. Anirudh. I just heard him, superb talk, one of the best talks on ultrasound and endometriosis that I have listened to. And of course, thank you very much. And I'm sure I missed the initial session of chief guest, Dr. Mandakini Meg, Dr. Subhash Malya, Dr. Pratibha Singh, the guest of honor, and Dr. Sujeshri, you are convening very, very well. So thank you for the kind introduction, Dr. Valang, Dr. Kirti Tandon, chairperson, and Dr. Sarita Agarwal, ma'am. So I shall be talking about endometriosis through the laparoscope. So after an excellent lecture by Dr. Anirudh, actually we have Dr. Anirudh in Mumbai also, Dr. Anirudh Badade, who comes to our center. And I think all of them are such excellent radiologists and doing very, very good work. So what I shall be talking will be endometriosis through laparoscope. However, when we talk about laparoscopy, now the consensus statement is very, very clear. First of all, we should know when not to do a laparoscopy. So now the clear guidelines are, if the patient has infertility, but she's for IUI, we do not need to do laparoscopy. We can do a decent ultrasound. We have good imaging modalities available. And the only thing we got to know is whether the tubes are patent or not. So we can do HSG, SSG, HICO-C, or whatever possibility you have to do at your center. So insufficient data to recommend laparoscopy before any kind of ovarian induction, ovulation induction and IUI, unless there is something which is showing you that, okay, we need to do a laparoscopy. Now, Eshrey went a step ahead. Eshrey said that suppose you're suspecting endometriosis in some patient. Okay, so earlier, we used to say diagnostic laparoscopy is the gold standard. But today they say that we can just do imaging combined with empirical treatment. हमने sonography कर लिया, sonography में we know that she does not have any deep endometriosis, there is no nodule, it may be a superficial peritoneal endometriosis. So those patients can be given hormonal contraceptives or progestogens, and if she feels fine with the medication, then we do not need a laparoscopy to diagnose. And there is no evidence of superiority whether we do diagnostic laparoscopy or we do imaging with an empirical treatment. So most of the times we get patients with infertility, with endometriosis. So what all we have to look at, we have to look at what is the duration of infertility, whether she has pelvic pain. So there are only two indications to put in that beautiful scope of ours. One is pain and second is infertility. And not all infertility patient would require a laparoscopy. So when we, if we have done a laparoscopy, we find it is stage 1, stage 2, patient is less than 35 or she has a good ovarian reserve. Okay, so those are the patients, we can treat them at laparoscopy, and then either we can just tell them, okay, go ahead, try naturally, or we can do mild stimulation with IUI. So this is clear. Now, if the patient is over the age of 35 or her AMH is like 1.1, 1.2, not too great, so those are the patients we can advise them either again IUI is an option or we can advise them IVF. Now, whenever we find these peritoneal lesions, suppose when a laparoscopy, I put in a scope and I find this peritoneal lesion, she has infertility. She probably also had a fibroid or some other indication where I put in the scope and I found that she has got peritoneal endometriosis. Now, these lesions, if they are scattered, we can just take normal saline को just inject it under the peritoneum. So that area comes up, or we can also inject vasopressin. So the little bit of bleeding we can see here, that will also not happen. And then we can just resect this peritoneum, and that is the end of the story for this patient. Now, sometimes we may find these small nodules. I'm sorry. Sometimes we may find these small nodules. So you can see this nodule over here, these scattered nodules all over. So what we can do is a small tip, take a sponge holder and put it in the posterior fornix. The moment we put it in the posterior fornix, it becomes very clear and it becomes easy for us to do a bipolar. Second thing is that we must lift the ovary up. So slightly lift the ovary up and then do the coagulation, very superficial coagulation at the base, because these will become big endometriomas. Mind you that whenever we are treating peritoneal endometriosis, we are not dealing with any kind of a deep infiltrating endometriosis, because that will not be managed by just fulgurating or just superficially coagulating these lesions. So what do the Eshrey guidelines tell us? Whenever endometriosis is identified at laparoscopy, we should surgically treat endometriosis. Okay, so whenever we find this, we should surgically treat, and then it is called a see and treat approach as well. Why is this important? That suppose for some, you are doing a diagnostic laparoscopy. In a case of infertility, do not mention diagnostic laparoscopy. Always mention fertility enhancing laparoscopy. Because in case you find endometriotic lesions which you are suspecting, that is why you are putting in a scope. In that case, you are able to treat those lesions at the same time. Because in this now scenario of all the medical legal things, patients are getting videos in hand. So we must be very, very clear what in the documentation, what is the diagnosis we are writing, what is the procedure that we are writing, and what actually we are doing for the patient. Now, suppose we find small endometriotic lesions, then what to do with those lesions? In a small endometriotic cyst, we have already diagnosed that cyst. We see it when we put in the laparoscope. So these we can use a monopolar needle, you can use a harmonic, whatever you have. And then the most important step in this surgery is to go just behind the ovary where it is stuck and lift it up with the help of a suction irrigation canal. So this is the most important step, that this step, that lifting this step, and then we coagulate. So once we lift the ovary, it becomes free. So in cases of infertility, which is because the tubo-ovarian junction is not optimal, so these are the patients that will be benefited with this kind of a surgery. Now, this lady, she's a 31-year-old lady, primary infertility for 3 years, male factor is normal, severe dysmenorrhea, dyspareunia. Sonography shows endometriomas 4 and 5 centimeters bilateral. She has had 3 cycles of IUI done outside already. Her tubes are patent. Her AMH is 2.9. So what to do next? So let us just give time for everyone to think about this patient, just visualize this patient. So she has severe pain, she has severe dysmenorrhea, severe dyspareunia, and her AMH is not bad because she's young, 31, her AMH is 2.9. So I'm sure everybody will agree that this is the patient we may put in our laparoscope and treat bilateral endometriomas, keeping in mind that first surgery is the best option for the patient. So we should have the skills to operate, and if required, we can also have a good assistant who can help us for these surgeries. In these patients, of course, when we talk whether we should do ART or we should go for surgery, 2 factors for surgery. One is she has pain. So pain is there, we have to treat the pain. And second, of course, is her AMH is decent, 2.9. Her ultrasound is correlating with her AMH value. So these are the 2 factors, and she is young. Now, same patient, if her AMH was, say, 0.9, 0.9, same patient, same complaints, in that scenario, I would probably first go for the ART, pick up the eggs, freeze the embryos, and if required for the pain, then go for the surgery. So we many a times we have to change our mindset depending on how the patient is, what is the age of the patient and what is the presentation. Now, whether to go for a cystectomy or whether to go for a drainage. Now, there are many options. One, of course, we can do a drainage and come out. Second is to remove, this video is not, second is to remove this entire cyst. So what we do is, we actually inject some vasopressin, right? You can inject it in the broad ligament or you can inject it just between. So you go tangential, the moment you go see the at right angle, it will puncture the cyst. So always at an angle of say 45 degrees, and then you inject vasopressin and then do a cystectomy. Even when we are doing a cystectomy, then there is always a possibility that some follicles are getting stripped off. right? So there are also some studies showing sclerotherapy, which we can discuss at a later point of view. At this point of time, cystectomy is a better approach as compared to just drainage and then coagulation, because recurrence rates are high if we do drainage and we do coagulation. So, what do the guidelines tell us? That in endometrioma surgery, where we are doing it for fertility, we should do excision of the endometrioma capsule instead of drainage. And we used to do drainage and electrocoagulation. I have done many cases, but now we are following what is the data telling us, evidence telling us, also all of that. So whenever we are doing the excision of the capsule, we have to keep in mind that her AMH values, her ovarian reserve is going to come down. So counseling is very, very important. Patients should not suddenly say, doc, you did not tell me that my ovarian reserve will come down. Otherwise, I wouldn't have gone in for the surgery. Or I would have frozen my eggs before the surgery. So fertility preservation, again, very, very important. Suppose I get a young girl, she's like 25 years old, and she has two unilateral endometrioma. I probably would put her on a medical management. While I'm putting her on a medical management, and suppose she's sexually active, I would also touch upon the topic of egg freezing for her. She's not ready to get married for the next 5 years, not ready to have children for the next whatever number of years after marriage. So any patient coming to us with endometriosis, we should tell them that this option is there. Endometriosis as a disease, whether we operate or we don't operate, it does reduce the ovarian reserve. So beware of those who already have low ovarian reserve, and best avoid surgery in this group. So those are the patients where we need to keep in mind that go for the egg pickup. Even if you need to do the surgery for some reason, either she's having a lot of pain or the cyst is very, very large, so better to first do the egg pickup. So AMH levels about 40% are reduced after laparoscopic excision. And even normally, suppose I have a 30-year-old lady with endometriosis and another one without endometriosis. So the patient, even without the surgery, the ones who have endometriosis, they have lesser ovarian reserve as compared to the control. Now, one more question comes up. This comes up every time. कि अगर endometriosis है, patient is for IVF, अगर हम उसको surgically treat करके IVF करते हैं, so will that improve the results of IVF? Now, what does the evidence tell us? So this was a nice study where they did IVF for surgically treated or intact endometriomas. What did they found? They found the similar pregnancy rates in both the groups. However, in patients who were treated, who had a surgery for endometrioma, they had a lower AFC count, they had higher dose required, and they took longer to conceive. Now, in our scenario, taking longer to conceive means all those expenses also for the patient, which in some countries does not matter because the state is paying for their IVF cycles. So clear guidelines by ESHRE. So if we have an endometrioma, there is no evidence that cystectomy prior to treatment with it will improve the pregnancy rate. So no evidence. So we do not have to operate on the patient unless she is having severe pain or here or there is a problem in the accessibility of the follicles. And we should counsel that if we are operating you, it will reduce your ovarian function. That should be told to the patient. So another study, what they did was they took an egg donor, okay, and they transferred the eggs, the embryos from the egg donor to one lady with endometriosis and the other lady without endometriosis, and they found similar pregnancy rates. That means the problem is not with the uterus, it is the problem with the quality of the eggs. So even we see in our practice, whenever we have a patient with endometriosis and I do the pickup, so my embryologist tells, Madam, bade oocytes bahut excuse me, dark color ke lag rahe hain, they are not looking very good. So the so the eggs coming from a woman with endometriosis, the quality is slightly compromised. Suppose we take eggs from the donor who has endometriosis and transfer it, create the embryos, transfer it to a lady who does not have endometriosis. What they found, the implantation rates were low. So it is again very clearly telling us the quality of egg is compromised in women suffering from endometriosis. So both the quantity and quality both are affected by endometriosis. So that has to be kept in mind. There is no evidence that agar humko ART karna hai and patient has stage 3 or stage 4 endometriosis, that there is prior to ART, if we do the treatment or we don't do endometriosis treatment before IVF and straight take the patient for IVF, so we can go straight for the IVF. If we operate on the patient, then the ovarian response may go down, the reserve may go down. So we have to keep these two things also in mind, and we are not getting better results of IVF. So we need to keep that in mind. So where we need to operate, maybe if the ovarian endometrioma 4 centimeters, some studies say 5 centimeters, some say 8 centimeters. If you ask me, I will not operate on the patient, even if she has a large endometrioma, as long as I can get the oocytes retrieved and transfer the embryos. Again, some young patient with recurrent implantation failure with endometriosis, you may want to operate, but very, very individualized thing that we have to keep in mind. If some patient we have already operated on her, but she did not conceive spontaneously, but she comes back. She says, oh, no, I have got another endometriotic cyst. So ovarian reserve is not bad. So those patients, again, ART is more effective than going for repeat surgery should be avoided as far as possible. We should not go for the repeat surgery. So this is another case at my center only. So she had an endometriotic cyst of 8 centimeters. Her AMH was very low. So she had a donor egg cycle. Okay, twice we transferred the embryos. We did not get any pregnancy. Now she had a relative in the US and who was a doctor. And she said, no, my sister is telling me you go for the surgery. It is because of the endometriotic cyst that you are not conceiving. Now, whenever we are doing infertility management, we have to also keep in mind the possibility of a negative possibility. Any 100 patients हैं, उसमें से 60 will conceive, 40 will not conceive, or 70 will conceive, 30 will. So statistically also there will be some patients who may not conceive, and we do not have to jump to a conclusion that this is why you have not conceived. Maybe she just requires a second chance or a third chance. However, the patient was very keen because her sister told her to get operated. So we went ahead. Okay, this video. So we went ahead. This was a large endometriotic cyst that she had. And sometimes we can use it because she anyway did not have much of ovarian reserve. We already have 5 blastocysts frozen from the donor. So we went ahead and just resected this endometrioma from the base. Now, what next? We again transferred the embryo in the 3rd cycle, and we did not get a pregnancy again. And I was thanking my stars that I did not advise her to go for the surgery. The surgery kiya aur aapko pregnancy ho jayega. However, she did conceive in the 4th attempt with the twin pregnancy and delivered at term. So these are the patients where we would go for a prolonged pituitary downregulation, and then we will go for the frozen embryo transfer for these patients. Now, sometimes with these patients, we have large adenomyomas, 14-week size, 16-week size, large adenomyosis. They may be accompanied with endometriosis. or just adenomyosis. Now the surrogacy laws have become very, very difficult. So can we do something surgically help them also for the pain? So we tried, this is the wedge resection that is being done for this patient, and we removed, it's like opening a orange or an apple. तो दोनों तरफ से scoop करके हमने निकाल दिया, and after we have removed, debulked it, then we do use a barb suture and use suture. So how we suture is we suture the edge of one side to the base of the other side, and then we cover it with the so the basic problem with adenomyotic surgery is giving way of the scar when they if they conceive. The conception rate is very, very low. At my center it is still about 20-25%, but yet yes, we can definitely give it a try. So but the patients who have conceived after the surgery, they have done well because of two reasons. One is use of barb suture, and second is use of a flap surgery to close for the scar. So I always feel the person who thought of barb suture, that मतलब उसको ये idea भी कैसे आया, and then he worked at it. I think that scientist is really given so much of happiness to so many women, and not only women, also to the surgeons, because we are so confident after using barb suture, whether in adenomyosis or in fibroid or other surgeries as well. So we need to individualize treatment in all endometriosis cases. Suppose we find an endometrioma and we are doing a pickup, there is a way we can always go around. However, if we by mistake still puncture it, then we do not, then you collect it in the separate test tube and then put the patient on antibiotics. And as I said, in advanced endometriosis, there is no evidence to support surgical intervention before IVF or surgical intervention for spontaneous conception. It is better to go straight for ART. Only if we are suspecting any kind of a malignancy, CA125 is high, or she is having pain, or we are not able to access the follicles because that endometrioma is sitting somewhere at a crucial place. So those are the patients you can consider going in for a surgical option before the ART. Also, endometriosis, we should know that it reduces the ovarian reserve. Jitna bada endometrioma hai, more advanced, the poorer are the reproductive outcomes of IVF. So that is why I said, even when they visit us, with small endometrioma, 29-year-old, married for 6 months, does not want to conceive right now, you can't force them. वो बोलते हम तो डॉक्टर के पास पेन के लिए गए थे, वो हमारे पीछे पड़ गए, बेबी करो बेबी करो बेबी करो. They don't like it sometimes, so it's a good idea that we can first of all give them the statistics, and second, you can preserve your eggs, you can preserve your embryos, and then maybe go for a transfer at the later date. So only patients who have mild to moderate endometriosis, then they have good ovarian reserve, then surgery may be the option in these patients. I have not covered any deep infiltrating endometriosis in my talk, because those are more of a number one, diagnosed cases on imaging, not only on laparoscopy. Second thing is, for that there are so many types and so many surgeries that we need like full one day if we are also treating that, if you are also discussing the deep infiltrating endometriosis. So thank you very much, and if there are any questions, we can take them. Thank you very much.
Thank you, Dr. Meeno. Over to the respected chairperson, Sarita ma'am.
Yeah, thank you, Dr. Asha, for inviting me on this forum. And Dr. Meeno, it was a wonderful, wonderful talk and very concise. You have almost covered everything in your talk. And the best part, the golden words are fertility enhancing laparoscopic surgery. Like, this is really great rather than saying a diagnostic. And second thing, you mentioned that whenever you do excision of the capsule, the AMH will decrease. We should always inform the patient, or we can go in ahead with the egg pickup and freezing of the embryos. Really a wonderful, wonderful talk. And you're really given insights of so many things that there is no difference in IVF, whether she's surgically treated or not. And it's so many golden words you have given. Thanks a lot. It's a wonderful talk.
Thank you, Sarita ma'am. Thank you. Thank you.
Kirti ma'am, would you like to add something here? No. So thank you, Dr. Meenu. Thank you so much.
Priyankur. Yes, yes. Is Priyankur there?
Yeah, Priyankur is there.
Yeah. Right.
So-
And another thing which I did not cover, I thought, is the sclerotherapy.
Yeah.
So,
Okay.
हाँ, तो स्क्लेरोथेरेपी में लेप्रोस्कोप डालते हैं पहले. लेप्रोस्कोप डालने के बाद we make a small kind of a nick on the endometrioma, very small nick. तो उसके अंदर फोलिस कैथेटर डाल देते हैं. फोलिस कैथेटर को इन्फ्लेट कर देते हैं, तो वो ब्लॉक कर देता है उसको. एंड देन फ्रॉम द अदर एंड, जो मतलब अपना ड्रेनिंग एंड है, उससे हम पहले सारा उसका फ्लूइड we take it out. It is only for unilocular cyst. Multilocular, it will not help. And then put ethanol in that. Ethanol से 2-3 बारी flush करते हैं. वो flush करने के बाद we take the follies out and then leave that capsule with the cyst wall, everything intact there. And we presume that the entire cyst wall is kind of cauterized with ethanol. So there is no follicles बाहर नहीं आते उसे. So the AMH does not go down as much. So that is just, I thought. Thank you.
Thank you.
Anybody has any questions before we proceed to the panel?
Would you want Dr. Walang sir to add anything, ma'am? He's still around.
Dr. Walang, sir?
Yeah.
Kirti ma'am?
Thank you, ma'am,
Yeah,
so
please.
much. It was such a wonderful presentation. With so many things new we have learned. I don't have anything to add anymore. Thank you so much.
Thank
for
you.
your-
Thank you, sir. Thank you so much.
Thank you.
Dr. Kirti, would you like to add something, ma'am? Are you around? Okay. So let's move on to the panel discussion. We have Dr. Asha ma'am as the moderator. So I request ma'am to please introduce the panelists and take the program forward.
मैं अपना इस रिश्ते का बोझ आपके कंधों पर नहीं डालना चाहती. मैं आपके घर से, आपकी जिंदगी से हमेशा हमेशा के लिए जा रही हूँ.
Somebody has the TV on. So,
रिश्ते से मेरा घर, हमारा तो कोई रिश्ता ही नहीं.
okay. Somebody has a TV on. So maybe start the panel now.
It
Yes,
sounded
ma'am, yes.
like it sounded like some patient suffering with endometriosis saying pain इतना ज़्यादा है.
But it was too melodramatic, you know.
Yeah, it was.
So now we start the panel. We have two experts, that is Dr. Priyankur Roy and Dr. Shaila Jayaprakash ma'am. We have 6 panelists, Dr. Ranjana Gupta, Dr. Lata Gupta, Dr. Sonia Batra, Dr. Deepika Agarwal, Dr. Sujata Kumari, and Dr. Uma Tripathi. I shall introduce them in short. So Priyankur, as we all know, is the chairperson of Public Awareness Committee, FOXY. He is also Associate Professor Lord Buddha Koshi Medical College and Hospital, Saharsa, Chairperson Public Awareness Committee, FOXY, President Vato, FIGO, MCM ISAR, India and Bengal, Member Women in Crisis. He's a very young gynecologist with a lot of associations and very, very active. So welcome, Dr. Priyankur.
Thank you so much, ma'am.
Next, we have Dr. Shaila Jayaprakash ma'am, who's a consultant obstetrician and gynecologist, JP Aradhana Maternity Center, Shimoga. She is president of Shimoga Society. and she's been working as medical officer at FPAI Shimoga for 12 years. She's done 12,000 tubectomies. Endometriosis is her area of passion. She's conducted many infertility camps and checkups for safe motherhood and pap smears. Welcome, Shelab Jayaprakash ma'am. Our panelists are Dr. Ranjana Gupta, who's the director and consultant Gupta Hospital, Patiala. She's the honorary secretary of Patiala Society, has 30 years of experience, and has an interest in high-risk pregnancy, ultrasonography, and infertility, obviously where we are headed today. We have Dr. Lata Gupta, who's the consultant at Lata Nursing Home and founder of Sitamarhi Obstetric Gynec Society, chairperson at national conferences, has received MS Signature Award, past president of Lions Club. Welcome, Lata Gupta ma'am. We have Dr. Sonia Batra ma'am. I think I've met you somewhere, ma'am, though you may not remember me. I'm really happy to have you. He is Chief Consultant Gynae and Endoscopic Surgeon, Ashoka Sanjeevani Hospital, Shimoga. She has done her graduation from Jabalpur Medical College, studied at GCRI Ahmedabad, Honorary Secretary Endoscopic Committee, Kasoga, Karnataka, and Honorary Secretary Shimoga Obstetric Gynec Society. Welcome, Dr. Sonia Batra ma'am. We have Dr. Deepika Agrawal, who is the secretary of Shahjahanpur Society, and she's an associate professor at Varun Arjun Medical College, Mathura. Her areas of her interest are high-risk obstetrics and infertility and gynec endocrinology. We have Dr. Sujata Kumari ma'am, who is an IVF consultant and lab surgeon, Jayaprakash Hospital, Rourkela. She is secretary of Rourkela Obstetric Gynec Society, and her special interest is IVF. She has a Youth Icon Award and teaching faculty of DNB trainees. We have Dr. Uma Mishra. She is a budding, very efficient gynecologist and lab surgeon from Raipur. She works at Shubh Hospital. Special interest in laparoscopic endometriosis surgery and oncosurgery. She has many fellowships, achievements, and memberships. Welcome, Dr. Uma. Really honored to have you with me today.
Thank you, ma'am. Thank you so much.
So we have heard a lot about what can be done in endometriosis. Now, we have certain introductory questions because we didn't have any theory talk. So just a few quick questions. Any panelist is free to give the answers. I'm not going to pose them to any specific person. So what is the prevalence of endometriosis among reproductive aged women? And has it changed over the past decade?
Can I answer? Should I start?
Yes, ma'am.
It's
Yes,
around
please.
10%, the prevalence rate, but the exact we don't know. The prevalence has been increasing. We have seen in the last decade that the prevalence is increasing because more of the awareness among the people, among the doctors, general practitioners, and the investigating modalities are there. Now we have ultrasounds almost all over the country, all the places, and the laparoscopies are there. So more and more patients are being diagnosed, but still we can't say that all of them are being diagnosed as the approach. Everyone can't approach the rural segment and then the poor segment. So everyone can't approach it. So it's not a confirmed figure. It's a roundabout figure of 10%. Though we
ma'am, one thing is, has the incident prevalence increased, or we are just diagnosing it more often? See, they are two different things. It's always been there, but now it is being diagnosed more, or the prevalence has changed. Any other person? Uma, would you like to say something here?
Yes, ma'am. Definitely, the diagnostic modalities and how patient come to a doctor with their all complaints. I think prevalence and incidence was same earlier also. Now they are seeking medical attention. That's how we are diagnosing it more and more, and we are more keen on treating it.
Can I
Okay,
add
so
something,
basically,
Dr. Asha?
yes, please. Yes, ma'am.
Asha ma'am, I feel that the incidence has also increased. It is not the same as it was 100 years ago. The reason being that the females were childbearing at that time, even at the age of 14, 15. And they were pretty much into amenorrheic phase. If you would traditionally go back in the history, the menstruation is the cry of the uterus for the want of a child. That has been taught in our early books. And at that time, I'm talking about yesteryears, the female, when she used to have her gona, she was already in her, after her first period, she would be at her in-laws place, would get pregnant very soon, lactate for a long time, then again probably 2 or 3 cycles of menstruation, and she would again go into amenorrheic phases. So when there were prolonged periods of amenorrhea, the chances of endometriosis were dramatically less. And it is now, when the girls have moved out and the childbearing has reduced, that is why the incidence of menstruation, the endometriosis has also increased.
Thank you. Any panelist has anything else to say here? Dr. Sonia?
Ma'am, can I add something, ma'am?
Yes, please.
Ma'am, I feel that the lifestyle has also changed a lot. So what happens is, as ma'am said, that previously childbearing was more, that is true. Apart from that, the feeding habits, the exercise is less, sedentary life is more, the stress is more, competition is more. That also leads to a lot of generation of free radicals, and that again is an additive cause of endometriosis.
Okay.
I think
Now I would like
it is both. We are diagnosing it more often, and definitely the incidence is also has increased. So
the infertility rate is also increasing.
Yes.
It can be, it's also one of the reason for this endometriosis.
Okay, so now for the final word, I go to my experts. Shaila ma'am, would you like to say something? No. Priyankur? So, Dr.
I'm
Anupama,
audible?
I think you are, yeah. Yes, Shaila ma'am.
Yeah. In adolescent also, there are cases of endometriosis. If it is diagnosed early, then the infertility also can be limited. They are coming, and their is around, the prevalence is around 47%. No, if
what
it is diagnosed
the prevalence
early,
of endometriosis?
yeah, it's around
among reproductive?
47%. Yeah. No, if it is that what I want to say is, if it is diagnosed in adolescent, this prevalence also comes down. It's around 47%.
But why it is increasing? That is a question.
So are there any genetic or familial predispositions?
Yeah, of course. Yes, yes. Genetic also is a close relative also may have, and they are genetically predisposed for the endometriosis.
So are there any genes that are known responsible for this, or it's just an empirical thing?
Genetically, genes.
We are seeing that women with first degree relative, like mother, sister with endometriosis, they are carrying high risk. Where we are seeing in the family. So that's why we are thinking there could be a genetic cause behind this. Because in one family we are seeing repeatedly. Other members are also suffering. So that's why we are quoting it. There could be a familial or genetic cause behind this.
Okay, but do we know of any genes? We know of tumor necrosis factor and certain things, but we still do not have a pinpoint diagnosis of any gene. So is there a difference in prevalence across ethnic and socioeconomic groups? Is there a difference, and what explains these differences?
Yes, ma'am. I would like to answer this question.
Yes, please.
Yes,
Go ahead.
ma'am. Actually, the endometriosis is prevalent across all the ethnic and the socioeconomic groups. But the difference is in the lower socioeconomic society or the areas where the this medical facilities are less. These things uh, are the reasons behind. We generally see that in the higher socioeconomic group, well educated group, they are more coming to us and more being diagnosed with endometriosis, while those from the lower socioeconomic or where the facilities are less, they are not so often coming to the medical facility. So that may be the difference we are seeing more in the higher group.
I think, here the term prevalence is what is not being really understood. Prevalence means the presence of the disease in the community. So when we say does the prevalence differ? And here I would go back to what Dr. Anupama said right now, that like in the previous times, women used to be permanently pregnant or lactating with very few menstruations. In the low socioeconomic groups, they still marry early. They still have early children, whatever the law might be saying. But still, they have early childbearing, and therefore, and they breastfeed for 2 years, 3 years. I have yet to see a case of lactational failure among a low socioeconomic group. That always happens with your ultra modern people. So I think that should be one of the reasons why the prevalence is less amongst the low socioeconomic group. Correct me if I'm wrong, Anupama.
No, ma'am. Perfect. I somehow feel
But we are
sometimes कि
seeing
वो
in
जो
adolescent
बाल
group,
विवाह
no,
बंद
ma'am.
कर दिया गया है वो बड़ी प्रॉब्लम हो गई है, वो
But we
probably
are
ठीक ही
seeing
था.
in adolescent group. This we are seeing in adolescent groups now. So how
Yeah,
you
but
can relate?
whom do you call an adolescent? Today you have increased the age of adolescence to 25 years, right? It's no more only 13 to 19. And therefore, when you say adolescent, what does it actually mean? When you're talking of adolescent, as we used to know it, that was between 9 to 14, 15. The West brought it up to 19, and now it's gone up to 25. So you do see dysmenorrhea and this and that. But the treatment
Also, these days, the menarche has also come up early. So that is also contributing to all the disease burden. And there is definitely a better awareness amongst we gynecologists, and we are diagnosing it earlier than before the endometriosis disease.
So what are the actual theories about why it happens? What are the most common theories that we have?
The most accepted theory is the retrograde menstruation, which can, whenever there is a menstruation, it is said that there is little bit of flow through the fallopian tubes into the peritoneal cavity, and this can develop into endometriosis. Then you have another theory is the coelomic metaplasia, and then the lymphatic and the vascular dissemination, where we are seeing the implantation of the endometrial cells in the pelvic cavity. Yeah, other than the pelvic cavity also, it has been observed. So this is the most
There is
commonest
a more
theory.
recent theory, which is the autoimmune theory. Does anybody want to say something about it, Sonia?
Yes, ma'am. The autoimmune theory says that our body's immune mechanism itself becomes attacking. Body's immune mechanisms itself is attacking the own body, because what happens is this implants. Autoimmune means they lack the phagocytosis kind of a thing, which is usually there in the innate immunity what we have. But this phagocytosis goes for a toss, and failure of this leads to more amount of oxygen and free radicals over there, which actually increases the growth of the endometrial tissue. And that is why we say that autoimmune also, and more of inflammation is seen over there, more of angiogenesis is seen over there, and this itself explains the theory now.
So that is the most recent theory and currently the one that is most in favor, and that is the autoimmune, and that explains why it can happen in young girls and with anyone. What are the hormonal factors involved in the development and progression?
Ma'am, shall I continue or?
Yes, go ahead.
Ma'am,
Then
hormonal
I'd like
factor
Dr. Ranjana to add something after you.
Okay, ma'am. Okay. So, ma'am, estrogen is the most important hormone, which is the culprit over here, which is studied. And we say that more of the estrogen receptors are there. That is why this hormone, if it is increased, it increases the proliferation of the tissue, and we get more of endometriotic tissue over there. And the fact which supports it is, as soon as we give progesterogenic supplements to the patient, there is a decrease of the endometrial proliferation, there is decrease in the angiogenesis, and that is why we get good results with progesterones. And so I think this is the correct answer for that.
Okay. So Dr. Ranjana, would you like to add something here?
Though it's like estrogen dependent condition, but we do see this thing endometriosis in the menopausal patients also, though to a lesser extent, but the theory is the same. Like the estrogens, they are from the periphery, they are the hormones are there, or the HRT is given. So basic principle is of estrogens only. It's a estrogen dependent thing.
Okay. So we've already dealt with the immunotherapy. Now we come to the medical management. What do you think in your practice? What is your first line? Do you give OCPs or do you give progesterone or you want to give Caberlin? What do you give?
Like, to me, should I answer?
Yeah, I will take it from everyone. You start.
Okay. Like empirically, if it's not a diagnosed endometriosis, first of all, the patient coming with pain, I would give OCs, oral contraceptive pills. If there is no, would ask all the complications, like if the patients like for the estrogens, if nausea, nothing, then I would like to give her the oral contraceptives and see the result for it. After 1 month, see the result, was it? If it is good, then I would continue it for 6 months.
Do you think 1 month of OCP will give you any result?
No, not result, but if she doesn't have any side effects of OCs, like sometimes patients don't tolerate OCs. Okay. Then they come with, or like I don't want it, then you can shift to. Otherwise, if the patient is having like, there is no problem taking it, then I would like to continue with the OCs. There is no breakthrough bleeding.
What dose do you want to give?
Pardon?
What dose do you want to give of OCPs?
I think 30 micrograms of it.
No, you're going to give it cyclically or you're going to give it continuously? How do you want?
First month cyclical. First month cyclical to see the response of the drugs. And if it suits her, then I would like to give her continuous. That would be better. There is no menstruation and then the side effects would be less and then she won't have pain. So it's better to give continuous pills.
Okay, so
20 to 30 micrograms would be sufficient of ethinyl estradiol plus levonorgestrel or norgestrel we can add.
Dr. Lata, would you like to say something here?
You can
What
give
do you give in your practice?
I usually use estrogen and progesterone combination, that is Dynogest, where as a progestin combination can be used in this case, or progestin. Then sometimes GnRH antagonist to reduce the pain.
I'm asking you one thing. What is your first line? What is the first thing that you're going to give?
First, I'll give her NSAIDs for pain relief. If it is okay with this, then there's no need to add. Suppose if it is a mild case. But if she doesn't respond to this, then I will add the estrogen progesterone pills. It will be, at least I've tried this combination for 6 months.
Okay, now you spoke of GnRH agonists. So I come back to Dr. Sonia.
Yes, ma'am.
When are you going to give GnRH agonist and when are you going to give antagonist?
Ma'am, GnRH agonists and antagonists have the same effect, but the difference is GnRH agonists have the initial flare response, which is not seen in the case of the antagonist. And the antagonist has a rapid onset of action as compared to the GnRH agonist. So, and when I'm talking about agonists and antagonists, the side effect is about the bone marrow, bone mineral density. So they have a very bad effect on the bone mineral density. So I'm not going to give it to any
So that is what I
adolescents.
said. Which patient are you going to choose to give GnRH? Agonist or antagonist? How would you choose your patient? Which patient are you going to give it to? You're not giving it to everyone, right?
Yes, ma'am.
So whom are you going to give it to?
Ma'am, for my first choice is always progestogens. I don't start with it, and if this thing they are not happy or they are not having proper response, then only I will shift on to agonist or antagonist. In this also, antagonist is better as compared to agonist. So I would go for
I
this
think
thing.
I have not been able to explain my question, Dr. Ranjana.
Yeah, pardon, what?
Which patient will you choose for GnRH agonist or
It's
antagonist?
it's a second line drug. Last of all, if the patient doesn't respond to OCs, to progesterones, to Danogest, to DMPA, or we can try this thing, IUS.
Okay, Dr. Anupama, I come
would
back.
like to use the GnRH analogs, or if we are planning for surgery, then also we can use it, this thing monthly or 3 months. It's the last of all to be used. We all know that the bone density is there and the vasomotor symptoms are there. We have to give on add-back therapy. So GnR agonist and the antagonist to be kept at last of all.
Welcome, Priyankur.
Hi, ma'am. Yeah, so ma'am, if I can just comment on this question that you were asking. So it's an
Yes.
excellent panel that's going on, ma'am. Thank you so much for giving me an opportunity as well. So, ma'am, I think as ma'am have said, I think very appropriately said, I mean, agonist and antagonist, of course, at one point of time, analogs, GnRH analogs were the first line treatment that was used. But now we know that for 6 months we can use it, but after that, due to osteoporosis, etc., we need to put the patient on add-back therapy, and that's why it has probably taken a little bit of a backseat. So agonist, yes, we have been using it for quite some time. Antagonist, now there's a ray of hope again that's coming with the alcoholic that has come in now, and probably if it's come in the oral medication, that's something that we can probably use in the coming few years. So I think the most appropriate place where we can use agonist GnRH analogs probably are in cases of ART cycles, etc., where we are planning to do a embryo transfer, etc. Just
Is
before
this the
that.
answer I was looking for?
So just before that, ma'am, probably we can give a shot of 3-month course of a GnRH analog or something and go for embryo transfer. Sometimes even in cases of endometriosis where you're probably operated and you want to do a pickup or something, in those cases also you can probably give an analog shot for 1-2 months and then stimulate the patient and go for a pickup as well.
Thank you. So that is what basically.
I would like to add something
Go ahead,
to
Uma.
it.
Yeah.
Even, ma'am, nowadays some people are using a combination of Dynogest along with GnRH agonist before doing ovum pickup and before going for IVF. So they are giving this 2 to 3 months of intense treatment to the patient before going for ART. So that is giving better results.
Yeah, so the basic thing is you're going to use this when the patient is going for ART. If she's an adolescent, you're not going to give her an GnRH or anything. It's basically when she is taking treatment for ART. Dr. Anupama, would you like to add something here?
Yes, ma'am. Basically, I just wanted to add 2 points here, that GnRH agonist is not to be considered for the scenario which you were presenting, the younger females or something. It is to be reserved for short-term treatment. Short-term, I mean that patient pre-pickup, post-pickup, before embryo transfer, that is probably the best time, because we can just use it 2 or 3 or max 6 shots in a lifetime. So it is to be judiciously used. And usually I, as a practitioner, am very fond of using agonist, but the only cases in which I'm repeatedly using it is the ones post-pickup, before embryo transfer, because usually the patients are hyperestrogenic state patients, and they also have concomitant adenomyotic elements as well as fibroids. So it deals with all of those. So that is why agonist is a very good therapy for those group of patients. And it is, if at all we are using it for a short term in other patients, sometimes, they have really bad chronic pelvic pain. Sometimes once a year or twice a year, I get such patients. In those, everything else has failed. We have tried everything else. So in those patients, under progesterone cover, I would give this GnRH agonist because I'm scared of the initial flare of the pain. But then along with GnRH agonist, I usually give them the long-term one, the 11.251. And I would want to add medroxyprogesterone in these patients because that will deal with the osteopenia part somewhat. And I would also want to add letrozole in those group of patients. But these are all, resistant group of patients. And it is definitely, as Priyankur and ma'am, everyone is saying, GnRH agonist is not a primary treatment. And antagonist is, as it is, not a treatment at all. Right now, egalagolix is not even available. So antagonist as a treatment for endometriosis, we are not using. It is only in the pickup cycles that we are going for antagonist protocols and not as a treatment and a medical management part of endometriosis.
Priyankur, you want to add something to this or we go further?
No. I have completely agree with what Dr. Anupama has said. I think absolutely very valid points and well taken. Exactly what I also meant, and it's the same. So we can go
Priyankur
ahead.
and myself are
Ma'am, I
always
have
hand in
one
hand.
question. Recently, I had an adolescent girl of 22 years who had endometriosis, and her CA 125 was very high, 181. So some suggested that she has to receive 2 doses of GnRS to suppress the CA 125 levels. I have
And
just
how
wanted
long will you give it? You can give it for a temporary thing, but it is no use for giving it. Better is to put her on Dynogest for long term. That unmarried girl, if you're talking of.
Yeah.
Or else if she is married, she should plan. I always tell my patients that the first thing you should attempt is a pregnancy. If a girl is unmarried, obviously, I always tell the parents to get her married and then plan for pregnancy, because there is nothing as good as pregnancy. The decidual changes which would happen in the endometriotic patch is the thing which we are desirous of. And all these treatments, the medroxyprogesterone, the OCPs, everything is finally Dynogest, everything is causing a decidual change. So why not attempt for a pregnancy? That should be the best treatment. And if the patient would not get pregnant in a short course of time after marriage, I will have a very low threshold of ART in this group of patients.
Agreed. And ma'am, Asha ma'am, if I can just add on one more point to
Yes,
Lata ma'am's
please,
question.
please.
Yes, so ma'am, Lata ma'am, I think that's quite a scenario that we see in endometriotic patients, because normally we say the ACA 125 cutoff is 40, but if you look at patients with endometriosis, they are sometimes in the range of 120, 130, 140 is the range that we normally see them at. But then again, remember in endometriosis, we can take a cutoff at approximately 200. So when it goes more than 200, that is when probably we are thinking more towards malignancy. And also we look at the RMI index, etc. in those cases, and then probably take a call of what it is. But then, as Anupama ma'am said, I think pregnancy is the best thing that we can look at. And also, as you know, the Dynogest, there's a study which has been done recently, published in 2022, which said even in adolescent girls, Dynogest can be used non-stop, that is continuously, for a period of 7 years. So you can
I have
definitely
a young patient who
Yes.
I diagnosed endometriosis when she was 18. And at 21 years, she was studying in Pune and she came and she had a CA 125 of 474 with an 8 centimeter endometrioma. But with long-term Dynogest, it disappeared.
Perfect.
So
Yeah.
it works. And her CA 125 came back to normal. So that CA 125 is not an indicator. She was in a panic. MRI was done. Everything was done. And everything was negative. And just with Dynogest, she responded very well.
We can give it up to 7 years.
Yes.
Dynogest.
You can break for 6 months and continue for indefinitely.
Thank you.
So now what is the role of lap surgery? Meenu ma'am has dealt with it so well. And I have a lot of laparoscopic surgeons here. So if anyone wants to say, when are you going to take the patient for laparoscopy? Just a short answer, when you're going to take for laparoscopy.
when there are ultrasound findings of endometriomas and the patient fails for the medical treatment, like you said, you put the patient on Dynogest, that endometrioma disappeared. You are putting the patient on medical management, still the patient, adolescent girls are having pain, not treated with anything. Then you can take the patient for laparoscopic surgery and you can clear off the endometriomas.
See, today our topic is chronic pelvic pain. We had done one whole webinar on chronic pelvic pain that was unrelated to endometriosis. And today we are taking endometriosis. So when a woman has chronic pelvic pain, maybe you put in a laparoscope and you find nothing. Because once she has been in pain for a long time, the mental triggers are all set in place. So that you have to understand, unless you really have evidence where you need to put in a laparoscope and you would be able to relieve her symptoms. Merely putting in a lap would not really relieve her symptoms.
It is only for diagnosis.
Ma'am, again for diagnosis also, I would say in the current day, ma'am, if you look at, we should not do a diagnostic laparoscopy just to diagnose endometriosis. I would quote Professor Shafran, who's known as the father of endometriosis, in ESHRE 2021. He mentioned that endometriosis should be solely a diagnosis of imaging. Do a good transvaginal ultrasound where you will see the endometriomas, etc. If you have a superficial or a deep infiltrating endometriosis picture that is there, it's best to probably do a MRI scan. Do not put in a diagnostic scope just to diagnose endometriosis. Do it if you're doing it with any concurrent procedure, like you want to do a tubal cannulation or something of that sort, you can do it probably. But just to diagnose chronic pelvic pain for endometriosis, do not put in a diagnostic scope. So I think imaging is the best modality for you to diagnose. And since we were talking about the medical management, I think we also need to remember, Lata ma'am, though you said your patient was unmarried, but of course we know, sexual contact is not something that is very uncommon in today's day. And if a lady has had sexual contact, probably you can counsel them of LNG IUS also, because that is a treatment modality that works also quite wonderfully. So that is something that you can remember in your patient as well.
Okay. So thank you for that. And now, are there any promising new treatments or research developments for the management of endometriosis? Any new research that we have, what can come in the future? Like Priyankur just said, it could be an LGIUS.
Elagolix is there, ma'am. We have letrozole, we have cabergoline, etc., which are also working wonderfully. We can look at those things also as treatment options in these cases. I'm sure there are other options people would like to add on as well.
This vaginal danazole is
have
also
a role.
one.
Do you have any experience of anastrozole in endometriosis? Anyone?
I have been using letrozole, madam, aromatase inhibitor, and as a routine, I'm using it on one of those patients who are not planning for fertility. So long-term letrozole along with Dynogest. That is.
You use both Dynogest and letrozole.
I usually do not use Dynogest, although it is documented as better. I usually use medroxyprogesterone, and that's cheaper. So I use medroxyprogesterone along with letrozole.
What dose are you using of medroxy?
10 milligrams, madam.
OD, continuous.
Continuous, yes. And ma'am, I wanted to add that vaginal danazole is also one treatment which has come up. Studies are still not that much available, but I heard it on one of the webinars only. One of the speakers, very learned speakers, he had a series, and he said that the danazole is going to come back because as an androgenic side effect, we were not using it, but vaginal 200 milligrams, he said that is going to be the future. Let's see. I have not used it ever.
How about continuous OC pills, or anybody has an experience?
Yes, ma'am. OC pills, I am surprised that why it did not come up earlier. OC pills are the primary treatment, but in those patients, you know what, if I may say so, my own daughter I'm just sharing my own story. My daughter, she's 17 years only, and she is having chronic pelvic pain. And nowadays, being so much into this endometriotic field, I feel that those girls who are having continuous dysmenorrhea, somehow they are the ones who are having more of endometriotic tendencies. And in this group of patients, if we are putting them on low dose OC pills, so I had a word of quite quite good gynecologist in our country, what all would be their preferences. After consulting so many of them, finally I have started her on drospirenone and ethinyl estradiol combination, the 24+4 And within 2 months, I must say that her dysmenorrhea has dramatically reduced. I have not given her any analgesic thereafter. Otherwise, this analgesic which we were giving was just that 8 hours effect, and it used to come back. I somehow feel that seeing so much of endometriosis in my infertility practice, I'm scared of that for my daughter. So what can I do early? So this is what I have been doing on my daughter. And I strongly believe that this is going to be the future, and we are going to use more and more of OCPs with low dose of estrogen. We are reducing the body cyclical rhythms and rather giving that a slow transition to the body, which would be better for the girls.
Well, recently, dydrogesterone in higher doses is being advocated in endometriosis. Anybody has the experience with this? Dydrogesterone is 30 milligrams. They are telling.
I always feel dydrogesterone is too much industry pushed molecule, but it does.
Really, same
Yeah.
here.
Actually.
So now we proceed with the cases, and I have 6 cases. We are going to take 3 to 4 minutes per case only. So this is a 24-year-old. She presents with severe dysmenorrhea, which has progressively worsened over the past 3 years. She also reports deep dyspareunia and chronic pelvic pain that disrupts her daily activities. So, this has to be just a quick recap. We've discussed everything. What are the clinical features that suggest endometriosis in this patient?
Severe dysmenorrhea, which is progressing.
Yes, and deep dyspareunia.
Deep dyspareunia.
Yes. So, what is the first modality with which you would evaluate her?
Transvaginal ultrasound.
Transvaginal ultrasound.
Okay.
Ultrasound.
Transvaginal ultrasound. What is the initial medical management? Suppose she finds endometriosis in her period.
NSAIDs and oral pills will be tried.
Okay. Now she is scared. She has read a lot on the internet and she's saying ki pills will cause problems to me. Hormones are bad. So how are you going to actually counsel her about it?
So basically, she is a young woman, and first we will counsel her that medical management is the first line of treatment, which is advised. And the first line of management is always the hormonal, and we have a plethora of treatment modalities available, and we would counsel her about side effects of every kind of treatment, and then we would advise her treatment accordingly.
Okay. So would you want to do a diagnostic lab? Dr. Priyankur just put this into this, that you are not going to do a diagnostic lab.
No, ma'am. Diagnostic lab is just to diagnose endometriosis is not justifiable nowadays because we have so many advances in diagnosing endometriosis with the clinical history, with the imaging, with the MRIs, so many modalities.
You've put her on OCPs. You've put her on
definitely
OCPs.
Yes.
So, but what lifestyle modification and what additive therapy would you like to advise her to manage her symptoms?
Lifestyle modification as in healthy eating habits, regular exercise, and stress management, and in some cases we can advise acupuncture therapy also. So these are the modifications.
We just discussed the immune part. So would you like to add something towards that? You want to add some antioxidants or something like that?
Antioxidants we can definitely advise, but they don't have any clear-cut role in treatment of endometriosis as of now. No clear-cut guidelines or no clear-cut paper is there on that.
Supplements like
Just a
vitamin
placebo.
B12, magnesium, omega fatty acids.
Supplements we can give.
Yeah.
Yes, we can
If her
definitely give.
levels are abnormal,
It
they
will
need to be corrected.
They say some herbs like cinnamon and licorice root can also help in such cases. It's a holistic approach to such patients. Good counseling for these patients. We have to give them confidence because as it is a lifelong, they have to suffer with the pain and all this. So we have to build up the confidence in them, advising to take it positively, doing regular exercises, diet modification, having positive attitude. This all might help.
What effect is exercise going to have?
Then it will release the immunomodulators in the body, give us the strength to face the small problem. The bigger problem looks small when our body is fit. That is what mainly.
And here the problem is in the body. Yes, Dr. Meenu.
I think we should also do an AMH anti-ovarian reserve for this patient and maybe touch upon the topic, the point of fertility preservation. In case the AMH is low, she still has time to get married and have children. So I think that topic should also be covered.
Agreed. Agreed.
This can happen only in affluent societies. This cannot happen in
I understand, but even I mean, I have my patients. I mean, we have every month, everything. We have at least 4 to 5 egg freezing, and out of which there are about 30 to 40% are because of the poor ovarian reserve. Younger patients, not very old, either suffering or not suffering with endometriosis, both.
Well, ma'am, that's the future. So if we are first going to be motivated, only then our patients would be motivated enough.
That is the most important sentence, Dr. Anupma, that we need to be motivated first.
Exactly.
Yeah.
Also, it's surprising that even the patients who are coming from a very average background, if you explain to them well, they actually go ahead and they think about.
See, actually, in our culture, having children is at a premium. Everybody wants children. And if you explain to them that this will save your future fertility, definitely they're going to agree. And I don't think it has a very prohibitive cost. Is it?
Yes, ma'am. Agreed.
Dr. Meenu, you are muted.
We should just tell them we don't have to do it for everyone. So they may come back after 6 months, 8 months, they all go on the net, read about it, and then they come and then they say,
Exactly. I strongly feel that it actually percolates in the patient over next few months, and most of them would turn around it within a year, desirous of fertility. I would also want to add that, the case which you had said, the history which you gave was that of dyspareunia. So I am assuming that the patient is sexually active, and I'm assuming that even if she's not married, she is sexually active. So putting a probe would really give me a volume of information. And if I find the endometriotic tendency in that patient, I will really give her time. My staff really smiles at me whenever I find an endometriotic patient, and I always give them that 10-15 minutes counseling that, her future fertility, this is the problem of pain right now which she's facing, but her future fertility is at stake. And तब मेरी जान मत खाना, क्योंकि तब तुम मेरे पास में आओगी और फिर तुमको प्रॉब्लम होगी. So अभी से ही समझ लो कि तुम्हें शादी जल्दी करनी है, बच्चे जल्दी करने हैं. If you really tell them, one of my cousins who came with this history and she was so clear, 2 साल हो गए अभी मुझे 2-3 साल और बच्चे नहीं करने. But when I counseled her this way, within a year she came for IVF. So you have to counsel. That is what is very important.
Ma'am, can I add something?
Yes, please.
Ma'am, we have had a discussion about everything, but I think we didn't have a discussion about the psychological counseling of the patients which is very important in these cases, because nowadays we are saying that patients are very, emotionally very much dependent, and they are not emotionally so strong where they used to be in the previous years. So psychological counseling and that positive attitude to build up is very important to have a good compliance with the medicines also, because if she's mentally strong and she's not feeling depressed, then only she'll be actually abiding by our treatment and she'll be regular with us. So I think that plays a very important role.
One more thing which I wanted to add was, Madam was asking about lifestyle modification. The most important thing which I feel is correct circadian rhythms. That is become a big problem, and the correct circadian rhythm would tackle a few things. You should sleep at night and you should get up in the work in the daytime. That schedule, when it comes, then also the
hormones become correct.
Yeah,
Growth
the
hormone is released.
body physiology
the
would
body
behave the way
repairs
it should.
itself. So that is another very important point. And this is the second case. She's a 30-year-old with 2-year history of infertility and mild intermittent pelvic pain, but she has regular menstrual cycles and no significant dysmenorrhea. So what are you going to do? What diagnosis are you going to do for her?
Transvaginal ultrasound.
Transvaginal ultrasound, yes.
Yes, ma'am, we have to rule out other things also.
Yes.
By transvaginal ultrasound, we will get an idea about endometriomas and how the ovarian reserve is. But we also need to know about tubal patency, and we have to also look for the male factor, whether there is any difference in the count or motility. So we have to go with a wholesome approach towards the patient.
Okay.
Madam, I want to know, can HS be done in endometriosis patients? Does it allow for any progression of the disease in HSG and all?
HSG doesn't
If
cause
she
any
doesn't
difficulty.
have hydrosalpinx, you can always do it. Why not?
No. See,
Severe
hydrosalpinx, we really don't have to do a HSG. Hydrosalpinx is to be tackled differently. But if you are suspecting that, like in this scenario, the history which has been given, it is not necessary a patient of endometriosis. So you have to just go about on the line of investigation, and HSG, if required, would be done. Definitely, that is a very, very important investigation. And endometriosis is a very easy diagnosis, usually, even if they are small endometriomas, on ultrasound. So that is the primary investigation. Time has gone when it was said that laparoscopy is the gold standard. So now you will just go about as an infertility patient, and HSG is probably within a month or two, I will be doing an HSG in this patient. Sometimes in endometriotic patients, not sometimes, most of the times, the tubal patency is not the problem, ma'am. It is the disturbed tubo-ovarian relationship which is the issue. So HSG is not that useful an information. And sometimes there is a confusion whether that cystic mass which you are looking at is the hydrosalpinx or it is a endometrioma. That suspicion can be there. Today only one of the slides which Dr. Anirudh had shown was, it was very confusing whether it is an hydrosalpinx with lot of hematosalpinx picture or it was a endometriotic mass. So for those situations, of course, you will have to go for a further investigation. But usually, HSG is not the primary investigation. If you are actually looking at an endometrioma, I think you should move ahead and go for a lower threshold of ART. One more thing which I wanted to add. Sorry, I'm barging in and again, Dr. Asha, that throughout this discussion, we have not insisted upon one important thing, that while counseling, this is one thing which I feel should be a very important learning thing for the gynecologist. When I was not doing my ART practice at that time, if a girl would come with the endometriosis patient, I would waste her time for months and years giving her OCPs or Dynogest. Whereas ideally, that female should have been advised for an ART if she's not getting pregnant. we are not gaining anything by giving Dynogest or OCPs to girls who are desirous of fertility. You are rather postponing her pregnancy by wasting her precious years, because that endometrioma which is lying there is actually going to reduce her ovarian reserve dramatically 2 years down the line, or maybe even 6 months down the line. So in such patients, it is very important to do a enteral follicular count and AMH, and within 5-6 months, take a call. And if the patient is not getting pregnant, this is the group of patient where there is no role of giving OCPs. Don't waste her time looking at an endometrioma and giving her OCPs, because you are not doing anything for her fertility. So it is very important that patients' AFC are to be looked at, and if it is less, she should straight away be counseled for IVF and not waste it.
So you've answered question number 5. One question that I want to come back to my panelists is, you heard Dr. Minu explaining endometriosis staging. So does the stage have any effect on fertility? Means a stage 1 will have less effect and a stage 4 will have more effect. Is it something like that? Or is the stage unrelated to fertility?
Certainly it is related. Stage 3 and stage 4, if it's there, then straightway we have to prepare the patient for ART. ART means IVF. Straightway we have to counsel the patient. And if it is a minimal, like stage minimal or mild stage 1, then certainly this thing, ovulation induction and IUIs are going to help it. But stage 3 and stage 4, certainly the IVF is going to be helpful for her.
Yes, Dr. Minu.
I would like to.
Yeah, sorry. Yes,
Can
Dr.
I comment on this?
Yes,
Please
ma'am.
go ahead, Roma. Sorry,
Sorry. As said earlier also, that AMH, we would get AMH level done. If AMH level is good and patient is having stage 3 and stage 4 disease, so we can go for fertility preserving surgery before looking for the natural conception, because there are studies and there are papers showing that once we perform fertility preserving surgery, keeping AMH in the mind, and once the patient's AMH is already good, the restoration of anatomy and the restoration of anatomy will bring improvement in the spontaneous conception.
That is what Dr. Minu had shown us. So, Dr. Minu, you wanted to comment?
So it's not only the ART, which is, yes, so it is not only.
My voice is breaking. Yes, Dr. Minu.
It's only for the delegates who have joined. There are 2 ways to grade endometriosis laparoscopically. One is an Enzian classification, ENZIAN, and second is an AGL classification. So both are there on the app store. So you just go to the app store, download Enzian classification, and in the Enzian classification, you just have to fill up. पेरिटोनियम पे एंडोमेट्रियोसिस है, ओवेरियन सरफेस पे है, ट्यूब पे है, पाउच में है, if there any nodule on ultrasound, so all that you fill it up, and then you will get the score and the grading. So then it is more of a documented grading, and then universally everybody can use the same thing. So I suggest to everyone, that is what we do. We use Enzian. So use that classification, and whenever we are doing a laparoscopy with good imaging done by Dr. Anupama or Dr. Anirudh, so put those ultrasound features as well as the laparoscopic features, and you get an excellent grading. Then you would know what to do next for the patient, and then patient goes to somewhere else. They keep getting transferred from one place to another, so they can carry that whole thing bunch with them. And it's very simple. It just comes on your phone, everything with the images.
Dr. Minu, my question is that does the grading correlate?
I know,
with,
yes, yes. Yes,
does
yes.
it correlate?
It does, of course. So it correlate in the sense, suppose a patient is infertile and she has an early peritoneal endometriosis, grade 1 or grade 2. In that case, with good AMH. So if the AMH is good and the endometriosis is a small endometriotic cyst or small peritoneal endometriosis, we can operate, and that is the only cause for infertility, and then look for a spontaneous conception and go for IUI. However, even in mild to moderate endometriosis, if our AMH is not so good, in those cases, we should straight go for either the egg or the embryo freezing or straight IVF. If she has severe endometriosis, large endometriotic cyst with deep nodule, so those are the patients we should straight take them for IVF. When I say IVF, it could just be embryo freezing also. And then if required for the pain, we can do the surgery. And if there is no pain, there is no need to go for the surgery, and we can straight go for the embryo transfer. This is what the guidelines at the moment, the evidence, the data that is telling. So this is what we are following at our center as well.
Thank you so much. Thank
I
you.
would just like to ask one thing, that in some studies it is given that because of the hydrosalpinx which is there, it decreases the fertility and the implantation rate by 50%. So when we are going for ART also, is it required after freezing the embryo, we should go for clipping of the tubes and then we should go ahead with the embryo transfer? Is it like that, ma'am?
Yes. If she has hydrosalpinx, irrespective of whether she has endometriosis or she does not have endometriosis, and we are doing an IVF for her, ART procedure for her, before the embryo transfer, we must either clip or we should do a salpingectomy. That is because that will reduce your ART results. If you keep the hydrosalpinx, it is not zero, but that keeps on secreting that fluid. Generally it is blocked at the distal end, तो वो नीचे से थोड़ा fluid endometrial cavity में आता है, and the implantation gets affected. So irrespective of endometriosis, hydrosalpinx, lot of evidence, lot of data that we should either do a salpingectomy or clip it at the base.
So that is what I just wanted to add, that's laparoscopy not for endometriosis, this thing, but for clipping is required.
Sure. Yes.
So thank you, Sonia. And now we come to the next case. This is a hysterectomy has already been done at 38 years for fibroids and endometriosis, but the pain still persists. Now, what are you going to do? Why does she still have pain?
This is because
I would
of
like to.
yes.
Yes,
Sorry.
Manu?
Yeah, you continue, ma'am. Yeah, continue, ma'am. Yeah. Okay.
Go ahead.
It is the recurrence of disease because of incomplete dissection of all endometriotic nodule, or maybe due to incomplete surgery also, because the hysterectomy is not only solution for endometriosis. We have to diagnose it properly.
Uterus, tubes, ovaries, everything is removed. But she
Yes, that's what I'm saying. That's what I'm saying, ma'am, because not only uterus, ovary, because we are talking about POD, we are talking about bowel, we are talking about bladder, and so we have to see for recurrence. We have to get her MRI done, and we have to see whether the endometriotic implants are there. Then we have to go for excision, or we can advise her OC pills or medical management also.
So now she had a history of endometriosis, but she has been hysterectomized 2-3 years back. So do you want to look for some other causes of chronic pelvic pain, or you're just going to attribute it to recurrence?
It could be because of adhesions, some nerve damage, or other conditions like pelvic floor dysfunction, etc.
What do you think of osteoporosis? She has had a pan-hysterectomy done, so she would be losing bone.
Yes.
She would be losing bone, and you lose 5% bone in the first 2 years after a hysterectomy. So that by itself could also be a cause. So how are you going to differentiate that?
And with the help of the different imaging modalities, we can differentiate these things. And like it can be a case of chronic pelvic pain other than endometriosis also. So we have to go for TVS, we have to go for MRI. Even MRI spine screening can also let us know about the
Do you
bone
think
density.
she needs a DEXA?
Yes, ma'am. That can also be this
No,
thing.
because so if her DEXA shows severe osteoporosis, then do you think you want to give her an HRT? A case of known endometriosis, would you give her HRT? The cause is not endometriosis, but would you give her HRT? Supposing it is endometriosis that has caused this problem.
We have to be
Sorry, it is not endometriosis, it is osteoporosis because of which she has this problem. So would you give her HRT or not?
We can give, ma'am.
Definitely.
But with caution, ma'am, that we have to rule out endometriosis and we can start HRT, and we have other elements also with orthopedics, are very raloxifene and all those things, COX-2 inhibitors, all these things can also be given along with the calcitriols injections which are available, bone-based and all that.
Okay, so you want to take care of her bones but not give her hormones.
Ma'am, we have to give her hormones cautiously, I told ma'am.
Yeah.
Both estrogens plus progesterones. We have to add progesterones in it along with estrogens. Or
Okay.
Teflon.
Okay. So we have very little time left, so I'm just rushing through whatever is important. This is a 16-year-old, severe pelvic pain, heavy menstrual bleeding, irregular menses. She keeps on missing school because of pain. So how are you going to diagnose endometriosis in an adolescent, a true adolescent? She's 16 years old. She's not sexually active. What will you do?
Ultrasound or MRI is this thing. Otherwise,
An abdominal scan is not going to show anything unless she has an endometrioma.
yes,
Ma'am,
ma'am. So
MRI would be
MRI
a
would be
better
the best thing.
Okay. So she's been diagnosed endometriosis. Would you be concerned about future fertility?
Yes, ma'am.
Definitely, yes.
So at 16, what are you going to do? Are you going to suppress her hormones or are you going to put her on something non-hormonal? I remember when we started practice, it used to be that because she's an adolescent, she should not get hormones. Bones are still growing, epiphysis has not fused. So what are you going to do for her?
Lifestyle modifications, as you told, because this is not a disease of this age. Now, this is going to progress lifelong. So lifestyle modifications, her diet, exercise, all these things have to be taken care of. And her counseling has to be done, and we have to counsel her that she should marry early because this is a case of
that will be for her parents, but
yes,
this is somewhat what Dr. Anupama already spoke about. So early diagnosis and intervention. You don't want her disease to progress, so you're going to give her OCPs and you're going to support her. And what are you going to do about her mental health? Telling a 16-year-old that you have a disease that will stay with you all your life and it will impact your fertility. What kind of effect it's going to have on that child, as though, her life is over. So how are you going to manage that?
Ma'am, first we have to talk to her and see her mental condition, how she is, because when she's already in pain, we cannot counsel her much. But slowly, when she keeps on coming to me, then I can counsel her about these things. Then I can tell her that you are not alone. There are other people as well. And because it's a battle, you have to fight with it. That's true. But then you're not alone in this. So slowly, psychological counseling can help.
Okay. Dr. Ranjana, would you like to add something here?
We have to their family, the mother of the girl, we have to talk to her. And the girl, we can't say about the future, what would happen. Then the child would really feel bad and she would go in depression or anxiety. But we have to take the mother into confidence. We have to explain to her about the future course of things. And we have to just tell her that the OCPs, they are going to be helpful for her. And we have to keep her menstrual free, menstrual period free, so that the disease doesn't progress. And when we take care of the pain with NSAIDs and the OCP, I think the girl is going to do better, and we have to engage her in other activities. She should not think about it or talk about it or discuss about it with other family members or the relatives and all. I think that should be the approach with us.
Anyone wants to add something here?
I I think, ma'am, at this young age, we should better, regarding the counseling of pain and how the disease will progress, we should definitely give her a warm, then gentle touch and counseling. But regarding the infertility and how her fertility is going to progress in the future, we can make this thing understand to her mother because she is very young to bear all these things. Gradually, once her disease progression become less and she becomes adult, then we can let her understand this how this thing is going to progress. Because this will affect her everything, curricular field and studies, and she will have more of stress. So I think it's her mother whom we can make her understand regarding the fertility part.
Dr. Anupama, you want to add something here?
Yeah, but I was just wondering if something new comes up, but what I feel is the case which you said, I actually saw my daughter there, exactly the same scenario. She's 17 years old, everything the same. And I loved what Dr. Sonia said, that it is ultimately you have to tell her and give her a perspective in the long run when she keeps coming back to you again and again. So initially, I could not tell my daughter what I am scared of. She would say that every day you are looking at endometriosis in your OPD and you are suspecting that into me and you are behaving like a fourth semester syndrome. But ultimately, what now I have managed to do is that over the time, repeatedly, she has understood what endometriosis is. Even at the age of 17 only, she understands what I'm saying, that she is not 100% endometriosis, but she has that endometriotic tendency with all her symptoms. So what is the likely symptomhood, the spectrum, I should tell her that what happens, what can happen later on with the pain along with that decreased fertility. So these
See, what I would like to add in the
nowadays
counseling,
everybody is career oriented.
Yeah. What I would like to add here is that you need to first build up a trust with that patient. That is what Dr. Sonia said, because otherwise she just runs away.
Ma'am, kya
To say many things to her mother, and at that age, many of them are not even talking to their mothers. There's so much of peer pressure, and they're out in the hostel, they have different friends, they have the internet to tell them everything. So first step here is first to confirm your diagnosis, and the second thing is to develop a rapport and trust with that person, because otherwise we will not be able to do anything for that
I
patient.
love this comment, ma'am. I love this comment. वाकई इस उम्र के बच्चों का माँ बाप से तो रिश्ता होता नहीं. मेरी बेटी और मेरा भी वैसा नहीं है. बिल्कुल ठीक बोला मैडम ने. उसको दुनिया वाले बताएंगे कि ये है तो.
Yeah. So if somebody else tells them, if they get peer pressure, they read it on the internet, they are looking at you, and they are actually looking in their mobile and typing to get the information, and they want to corroborate that what you have said, does it match? So the first thing is to have a correct diagnosis. The second thing is to develop that trust, that you are there in a place where they can trust you and they can talk to you. So I think with that, we proceed to the last case. And this is a 47-year-old. She has new onset pelvic pain. She previously was told that she has endometriosis. She has no papers or anything. She says, I was just told 15 years back, but I had no problem. Now I'm getting pain. So for this patient, is it possible for endometriosis to worsen during perimenopause? Let us discuss science here.
Usually, endometriosis, it regresses with menopause because as
perimenopause, will it get worse?
It can if she's on HRT or any.
Anybody else? Dr. Sonia, Dr. Anupama, Uma, Dr. Ranjani?
I'm scared of malignant component in this patient. That really hits me, that I have to follow this patient. And this is the patient where I would really want to have an MRI and further investigate. HRT is
no, she's not on HRT.
Not really.
She is perimenopausal. See, everybody,
Oh,
from
yes,
the
then
first
definitely.
discussion, we are talking that it is estrogen based. What happens in perimenopause? You don't ovulate. Ovulation becomes less. So you have more estrogen. You have more of estrogen. That is making your
You
endometrium
have estrogen
hyperplastic.
deficiency.
Obviously, your endometriosis is going to get worse. It's basic science that we discussed in the first introductory part. So here you are obviously going to evaluate her endometrium. You're going to do her ultrasound. You're going to see for solid component if she has an endometrioma. So are you going to put her on any hormones? After evaluation, she has turned out endometriosis.
For the
diagnosis.
Yeah.
You want
Yes,
to put
yes.
her on Dydrogest, or you just want to put her on medroxyprogesterone?
The treatment IUS probably would be best for her.
So what is the dose?
I would go for
of
LNG IUS
medroxy?
after a
LNG
withdrawal.
IUS. Great. So
one thing I would like to add here, before adding LNG IUS here, I would like to ask her menstrual history, and I would like to see her transvaginal scan with endometrial thickness.
All that is done.
So,
We've done her transvaginal. We have a diagnosis of endometriosis. We have evaluated her endometrium. There is endometrial hyperplasia, but that's it.
I am very happy with LNG IUS when you took. Can I add something?
What did you say?
Should I start?
Yeah, go ahead.
Ma'am, I am very happy with LNG IUS when you told, because this is a perimenopausal age, and as you told that estrogen will be on the higher side, so progesterone, continuous slow release of progesterone will take care of that. Particularly perimenopausal, she'll be having that compliance will not be very good at this age, so we cannot expect her to take tablets every day, every time, and proper this thing. So I think LNG IUS is a very good option for her. This.
And with that, do you want some non-hormonal pain management for her? You've put in the LNG IUS.
Yes, ma'am. Yes, ma'am. Non-hormonal pain managements can be given. It can help her with her bone pains also. This pain also. NSAIDs can be used along with that.
Okay. Now we come to the end of the session, and I want take-home messages from everyone present here. Each and everyone, please give one take-home message. Thank you so much. Thank you so much for being here. Please do support my endeavor for Food Drug Committee. Vote for me. And thank you. I'll stop sharing and then we can have a nice chat. Yeah.
Thank you so much, ma'am. We will definitely support you in future.
Too much to learn.
So now I want the take-home messages. On my screen, I see Dr. Ranjana at the top. So Dr. Ranjana, I start with you.
The take-home message is I just came to know from this thing, Dr. Anirudh, the detailed of ultrasound. So I think that I would get my patients in this thing investigated for ultrasonography from a very good ultrasonographer, like Dr. Anirudh, who would give me details of everything he told, like for this thing, stage 3, stage 4, this thing, endometriosis, and to see the TOS sign and everything. I would just be looking for these findings in my ultrasound in the patients of endometriosis from now onwards.
Dr. Sonia?
Ma'am, I like your perimenopausal this thing that the estrogen will be high, and now I'll be actually putting LNG IUS for those patients, and definitely psychological counseling with those adolescent girls, as ma'am told. That touched me actually, that her 17-year-old girl, the daughter of a gynecologist itself. So I really feel like psychological counseling and bringing a rapport is very, very important.
Dr. Lata?
It was a very nice session, madam. I really got to learn so many things and meet all of you. From this session, I have learned that endometriosis has become it is increasing now. And number of patients we are seeing, it is increased. Adolescent girls also. Just today also I had 2 patients with the young girls who are having endometriosis. And really, I am worried why this tendency is increasing endometriosis. And all of us doctors, more research has to be done in this to give relief of pain to these girls. Sometimes the pain is so severe, I cannot, explain it. They come every time on and off with complaints of pain. And the next thing is the infertility. These two problems with our females, we have to tackle them. I hope more research will be done under your guidance, because you are taking now contesting election on the drugs, this one chairperson. So I hope more research will be done, and let us all give relief to our youngsters and our women of this area. Thank you so much.
Thank you, ma'am. Dr. Uma?
From being a laparoscopic surgeon, I would like to give a message that not every patient is for the operative, and we should selectively choose our patient, which patient will get benefited by operative treatment. Basically, the young girls who is unmarried and who is basically married also, but we should first try medical management. Then, if not treated by medical, then only we should resort to surgical management. And if at all that patient is requiring surgery, you should get it done by the best of hands, because the first surgery is the best surgery. So, yes.
Your message is first surgery. So do
Yes,
have
ma'am.
it done well. Now,
Yes, ma'am,
Dr.
definitely.
Sujata?
Yes, ma'am. What I would like to conclude, take-home message from here is that first we have a very good transvaginal ultrasound, so that we can grade the endometriosis and accordingly proceed with the patient. And every patient with endometriosis is unique, and we have to focus on her main problem, whether it's pain is the main issue, or infertility is the main issue, or any whatever concern she is, and accordingly we have to proceed with the treatment.
Thank you so much. Shaila, ma'am, are you still there? Priyankur, are you still there?
Yeah, can you hear me?
Yes, ma'am.
First of all, I would like to thank you, and best wishes and all the best for your election. And it was a very nice discussion with a key message of treating the younger age group and fertility patients also. It was a very good discussion. And I'm usually trying with even injection DMPA also every month for 3 injections, and that's also worked out very well, cost effective. With Dynogest also I'm using.
Thank you, ma'am.
Thank you.
Priyankur, are you there? So, Anupama, I come to you last. Just Meenu ma'am remains. Come on.
मैम मुझे तो बस एक ही बात बोलनी है सबसे, कि 2 बातें बोलनी है। एक तो ये कि मैम के पीछे, डॉक्टर आशा के पीछे जो हवा चल रही है ना, ऐसे ठंडी ठंडी सी, बड़ी प्लेजेंट सी, वो हमारी आशा मैम भी बिल्कुल ऐसी ही ठंडी ठंडी सी प्लेजेंट सी हैं। एंड एवरी वन ऑफ अस शुड वोट फॉर हर, बिकॉज आई रियली हैव मेरा बहुत इंटरेक्शन होता रहा है आशा मैम से टाइम एंड अगेन, एंड शी इज अ वेरी हम्बल एंड अ वेरी जेंटल पर्सन, एंड आई जस्ट विश हर गुड लक। एंड ऐसे लोगों को हेल्प पर होना चाहिए, दे आर सो अप्रोचेबल एंड सो मदरली। दूसरी बात मुझे
Thank you.
I would like to add one thing to Asha ma'am. When I was newly came to Raipur and I was very junior, so she is a kind of lady who will focus even in juniors also. She will let juniors also to come up and present their work and show their work. So she is that kind of lady.
I can see that. सब लोगों को हमको
Yeah.
दिख रहा था जिस तरीके से मैम ने ये पैनल कंडक्ट किया ना,
Yeah.
उससे वो जेंटलनेस एक्सूड हो रही थी बहुत
Yes,
अच्छे से।
actually.
One Dr. Anupama.
Yes. एक बात और बोलनी थी, बोल लो।
Yeah, it was very good interaction with you, Dr. Anupama. Very
Thank
nice.
you, madam. Thank you. So
Meenu
मुझे बस
ma'am, are
दूसरी
you
बात यही
still
बोलनी थी
there?
कि हाँ जी मैम।
Meenu ma'am, are you still there?
मीनू तो नहीं है, मुझे एक बात बोलनी थी, वो मेरी रह गई अभी तक।
बोलिए बोलिए।
मुझे बस यही बोलना था, मुझे किसी भी गायनेकोलॉजिस्ट फोरम पे बोलने को मिलता है, वो एंडोमेट्रियोसिस से रिलेटेड नहीं भी होता है तो भी बाय चांस ये एंडोमेट्रियोसिस का ही टॉपिक है। और वैसे मैं नेशनल एंडोमेट्रियोसिस कमेटी में किसी टाइम पर थी, तो तब से वो मेरे अंदर जो है आशा राव मैम ने घुसा रखा है। मुझे ऐसा लगता है कि एंडोमेट्रियोसिस इट्स अ सैड थिंग दैट इट इज वेरी वेरी underdiagnosed still in our gynecologist community, and even if we diagnose it, we are not treating it well. और हम बहुत पोस्टपोन करते हैं इसको, ट्रीटमेंट को। हम सिर्फ पिल्स पे और किसी टाइम पे डायनाजोल पे और अब पिल्स पे और अब डायनोजेस्ट पे चलाते रहते पेशेंट को। अगर हमारे पास में पेशेंट अनमैरिड आई है तो देन वी शुड आस्क हर टू गेट मैरिड. If she is married, we should ask her to get pregnant. If she is pregnant, she is trying for pregnancy, let her try for 5-6 months, and she is not getting pregnant in 5-6 months. Actually, there are a lot of inflammatory markers present over there which are damaging the egg and not letting it get fertilized. So it is better for these patients to go for ART, and we should refer those patients to our infertility friends. हमें बहुत अपना थ्रेशोल्ड लो करना पड़ेगा, बिकॉज बहुत बहुत सैड सिचुएशन है कि ये पेशेंट्स इतनी जल्दी डोनर पर आ जाते हैं, और वो मुझे बहुत बुरा लगता है कि मुझे पेशेंट्स को डोनर एग के लिए एडवाइस करना पड़ता है, जो मुझे 2 साल पहले उस पेशेंट का AMH 0.9 0.8 दिख रहा था और अब 0.01 हो गया है. सो दिस इज वन थिंग विच very very strongly I would say कि refer these patients to your colleagues. If you can treat it, very very good. If you cannot, refer them early. That is what helps.
Basically, don't cause iatrogenic infertility.
Right.
So,
I would like to, ma'am, shall I add something?
Yes, please.
Ma'am, you are a source of inspiration for me, not only you as a gynecologist, but because ma'am has done courses in accounts and, tax this thing also. And this is also a very important part of the hospital administration. So I have never seen any other gynecologist who is so active in such a way. But definitely, madam is a source of inspiration for me for in that aspect also. And I want, ma'am, just once again elaborate your degrees, what you have done in accounts, ma'am.
You're asking me?
Yes, ma'am.
I've done an MBA in hospital administration.
Yes, ma'am. You shared a story with me, ma'am, and that was very inspiring. That's why I thought, like, yes, that should also be.
The thing is, if you want to avoid being cheated, you need to increase your knowledge level. And this series is named Searchlight because I find that we all gynecologists have a mind like a searchlight. So we can put it anywhere and we can learn. So we need to learn to focus it on our patients, on our branch, and in almost everything that we need. Because if you do not know, you will be cheated. So as a doctor, I try to learn most for my patients, but I also try to make sure that I don't get cheated beyond a point.
Exactly.
So thank you so much. And it's been a very pleasant evening. I feel I'm very much with friends. Thank you so much for sparing your precious time. Thank you so much, Anupama, for staying till the end. Even Meenu ma'am is still here. So thank you so much. Thank you.
Thank you so much. Thank you so much.
सबसे बात करके बहुत अच्छा लगा. डॉक्टर सोनिया, डॉक्टर लता, एवरीवन, डॉक्टर रजना, सब लोग इतने वाइब्रेंट थे. छोटी सी डॉल ही है, मतलब बहुत अच्छा लगा सबके साथ बात करके.
Thank you.
Very nice. Very nice meeting.
Thank you, delegates, for being with us. Thank you so much. Now, with due permission, I will end the session. We meet next week again on Tuesday, and the topic is antenatal monitoring, what we should be doing. So welcome. See you next week. Bye-bye.
Bye.